Kericho County, and he just was able to witness firsthand what it looks like. What does a CHV do? And we talked to even a person who has benefited from the CHV, saying that now quality healthcare access has become so accessible to the extent that one CHV is working with about 100 people, and this, according to the Ministry of Health, is is enabling the country have records, of certain diseases that are prone to an area, as well as ensuring that they have records to the grassroots level. On the second day, we had the PSICT, Dr. Edward Kisiangani, who, yesterday we were leading the digital perspective in the health sector. Now, Kenya, like the West, is beginning to embrace digital technology, and this, is even spreading to the health sector. We are looking at virtual clinics cropping up, where you do not need to physically be at a doctor's place. You just, can sit at the comfort of your home, talk to a doctor virtually, and get your prescription. Actually here at the Kapkatet grounds, some of the residents of Kericho County have been a beneficiary of some of these virtual clinics. We also saw that, virtual reality is becoming now a reality in the training of these students. One of the issues that has been often spoke about is that, it has not been easy to access some of the labs which are critical for the training of some of our medical students in the country. And therefore, with this virtual reality, we have seen that students can now be able to be immersed in such realities like labs. They can be able to be there, not physically, but just through the technology. And we have seen that it has really helped them in learning and getting, the basics of what is happening without physically having to be in some of these labs, which they have said is costly to even have to be there. And as even the digital agenda is being propagated, the question now remains is, what about the financing bit? Even as Kenya tries to implement the universal health coverage in aid of the technology, then what about the financing bit? How will counties, together with the national government, come together and ensure that, they say that at the initial stages is where it is the most expensive to have the rollout and the systems to go. Therefore, we have seen that right now the clarion call is for, the financing. If they could get a little bit of financing and resources to ensure that, this transition to a fully digitized healthcare system is somewhat seamless. Today we are talking about human workforce, the human resource part of the healthcare sector. We have seen, strikes across the country of, the human workforce here, saying that, they do not have enough personnel. And it has been one of the issues that has been mentioned here, even as we expect the Cabinet Secretary Health to speak on it today. We're looking forward to see how can Kenya improve their personnel and ensure that, they can implement the strategy and retain the workforce that can be able to propagate a very fully digitized healthcare system in the country. We are looking about how can they strengthen the numbers, because it's not just having the numbers. How can they strengthen the numbers that even at the local level, in the mashinani, what can they do to ensure that even that doctor is fully qualified, has the necessary resources, has a team that can help them in ensuring that, they can provide adequate health care. This today, we are expecting that to happen right about now, where CS Health, together with CS now Public Service, Moses Kure, is expected to grace this occasion. We are looking at attendance of Kenya medical training students who are aspiring to be doctors, and even stakeholders in the health sector, just to have a feel, and maybe they can even probably just give their views on what do they think about the human workforce in the country. We have seen there has been calls to scale up on the implementation of some of the policies to ensure that, there is enough workforce in the country in regards to the health sector, and this is coming in at a time where the digital health landscape is taking really is beginning to be embraced in the country. Just behind me, we are looking at even drones. Who is manning these drones for the health sector? Therefore, there is the talk of having an all-inclusive workforce that can ensure that there is a fully working healthcare system in the country. And we are looking at the government trying to implement the universal health coverage in the country, which has also not been quite an easy task worldwide. So having the right financing methods as well as resources has been the call here to ensure that everyone who is participating, every stakeholder that is taking part in this conference has their voice on what the government can implement in terms of policy and ensure that this healthcare system that is now beginning to get digitized works. We will be giving you live updates as they come by here on TV 47 as well as Radio 47 in our subsequent bulletins. For now, let's just have a feel of the sights and sounds of what is happening here at the Kapkatet grounds. Let's have a look.
Nama shukran sana, tunakujia mubashara kabisa mtazamaji wetu popote unapotutazama, tukikujia kutoka uwanja wa Kapkatet katika kaunti hii ya Kericho. Haya yote yakiwa ni mazungumzo kuhusiana na mpango wa afya kwa wote. Tumekuwa hapa kutoka siku ya Jumatatu, siku ya kwanza, hapo jana siku ya Jumanne ikawa siku ya pili, ambapo tuliweza kuzungumzia masuala mbalimbali. Tukazungumzia afya dijitali, mikakati ambayo imewekwa na Wizara ya Mawasiliano na Habari, na vile vile tukaweza kusikia ni kipi waziri wa masuala ya afya Susan Nakhumicha alikuwa akiyazungumzia katika kuboresha afya vijijini, ama ukipenda afya nyumbani, masuala ambayo tumeyazamia siku ya leo, na tutakuwa papa hapa ili kukutaarifu mtazamaji masuala hayo. Bila kusahau tutakuwa tunazungumza na washikadau mbalimbali ambao wamejukumika kabisa katika kuhakikisha afya inaboreka na taratibu mwafaka zinafuatwa ili kuhakikisha afya ya watoto, akina mama, wanaume wote kwa jumla wanaweza kuangaziwa vilivyo. Bila kupoteza wakati, hivi sasa tunazungumza na Ruth Ngechu ambaye ni mkurugenzi mkuu kutoka shirika la Pathfinder International. Ruth, karibu sana katika studio zetu za muda tukiwa hapa Kapkatet, na labda kwa mtazamo wako tu wa juu, hii shughuli nzima ya mpango wa afya kwa wote kwako iko vipi?
Asante. Sasa venye naweza sema iko mzuri sana juu tumeanza kuongelelea mambo ya afya nyumbani. Hatuongelelei juu ya afya matibabu katika hospitali, zahanati. So tumeleta hii afya katika nyumba. Na kulingana na mimi naona hii ni mzuri sana, vile tunaona 70% ya watu wale wanaenda kwa hospitali hawafai kwenda huko. Ni vitu wanaweza fanyia kwa nyumba wakiwa na mtu wa kuwaelezea jinsi ya kujikiga, jinsi ya matibabu ya rahisi.
Mambo ya kuwa sawa sawa.
Oh yes.
Ndio, asante. Ruth, ndio naelewa fika. Tumekuwa hapa kutoka siku ya Jumatatu na tumeweza kuona washikadau mbalimbali wamefika hapa. Jana tumezungumzia swala la digital health, ama ukipenda afya dijitali, na ni hatua ambayo imejitokeza kwa sasa. Tuko kwenye mwelekeo sawa wa kuboresha afya
kabisa. Ukiangalia kama kila mtu, ama niseme sehemu kubwa ya watu wako na mobile phones ama access to digital tools. Ukitumia hizo unaweza fikia watu wengi zaidi, kuwapea mawaidha, kuwawezesha kufika katika kuwaelezea mahali wanaweza pata huduma za afya. So it is, for me, I think it is a very good initiative. We are trying to get to a digital era where people can access information, can access services at a click of the button. So kulingana na mimi, I think hiyo ni kitu ya muhimu sana.
Asante. Naelewa fika wewe ni mkurugenzi wa Pathfinder International, na si mkurugenzi tu wa Kenya, unaangazia mataifa mengi sana duniani. Wewe hapa ndio mnazungumzia katika Pathfinder International, kuna swala ambalo mnalizungumzia afya ya uzazi. Na mbona mkazamia afya ya uzazi na kando na yale masuala mengine, kwa sababu afya ya uzazi katika shirika lenu inajitokeza vilivyo ukiangalia katika yale mambo mengi?
Asante. Unajua afya ya mama na mtoto ndio inaweza elezea afya ya community or population. So sisi kuchukua hiyo hatua ya kusema we will be dealing with sexual reproductive health, it is to make sure that the population health is catered for through wanawake wajawazito ama wamama wenye wamejipanga vizuri kulingana na venye wanataka kupata watoto, na wale wanapata watoto tunaona kwamba wamepata ile huduma bora zaidi kutoka kwa nyumba, kutoka kwa hudumu wa afya katika hospitali. So we are trying to build systems where our mothers and their children can actually thrive. Pia ukiangazia kuna mambo zingine kama hawa wasichana wetu adolescents wametengwa kiasi, hatuwaongelelei sana. Kwa mahali tunafanya kazi unapata we have so many young girls who are pregnant, na tunaona sisi wanaafya ama wahudumu wa afya sana tunategemea kupata wale wamama wajawazito ama wamama wale wamefikisha miaka ya ile tunasema adult 18 years, lakini ukiangazia kuna mahali unapata mpaka 12-year-old anapata mtoto, 14-year-old anapata mtoto. So tunataka ile tunajaribu kufanya ni ku make sure hao wasichana wenye wanajitayarisha kuwa watu wazima wako na ile elimu ya kujua jinsi ya kujikinga, jinsi ya ku take care of their own health and especially reproductive health. Also tumeona pia kuna kuanga na uzito kwa community wakati wa mazungumzo kama haya. Kama mimi kuongelesha msichana wangu wa 12 years, 14 years, mambo ya uzazi inakuwa ngumu. Lakini tumeona we are having so many teenagers who are becoming pregnant. We are having so many teenagers who are getting HIV. So hatuwezi endelea hiding ourselves or burying our heads in the sand, whereas our children, our young people, our girls are actually engaging and end up becoming adolescent teen mothers. So tunawaongelesha, tunawapea mawaidha, na kama kuna lolote tunaweza fanya, also access to products, pia tunazungumzia juu ya hiyo, igawa tunaongelelea sana jinsi ya kujikinga.
Shukran sana, kwa sababu naelewa fika kwamba Ruth hivi sasa waziri wa afya Susan Nakhumicha amekuwa akizungumzia sana heri kinga kuliko tiba. Tuanze na kinga mwanzo alafu tupate tiba. Na labda tuangalie, tumezungumzia afya ya uzazi na tumejikita kwa mtoto msichana. Mara nyingi utapata kwamba tunapozungumzia afya ya uzazi ndio tutaangalia wale wasichana ambao wanabalee ama wale adolescents washafika hapo. Na wakishafika miaka fulani kuna wale ambao wamesaulika. Usisahau kwamba ukianzia miaka 35 hadi miaka 40 unapata kwamba wale ambao wako katika hiyo miaka aswa jinsia ya kike hawaangaziwi sana, kwa sababu tumehamasisha sana kuhusu wale ambao wana balee ama adolescents ili wasije wakapata zile mimba za utotoni. Hawa ambao wako miaka 35 kupanda, mbona wanasaulika? Nini kifanywe?
Kweli sidhani hiyo ni ukweli, sio ati wamesahaulika. Unajua kuna ile mpangilio ya spacing of children. Juu hao wengi wao wako kwa hiyo mpangilio ya familia. Kwa hivyo huwa tunawapea mawaidha ya spacing of children. Halafu kuna zile products zinaitwa family planning products. So tunawaelimisha, halafu wanachagua ile italingana na venye afya yao iko na pia mapendekezo yao. Pia kuna kitu ya muhimu umesema. tunaongelelea wasichana sana, wa baba na vijana. Juu hawa watoto, hawa mama wanapata watoto na vijana na wanaume. Kuna kitu tunaita male involvement. Juu hatuwezi hii mambo sio ya one gender, ina involve two genders. So tunaleta pia vijana pamoja. Tunawafunza actually ku appreciate your development ya wasichana, like being adolescents, menstrual hygiene and so forth, so that wakiona ama wasichana wale marafiki wao wanawasupport na wanaelewa what is happening to them, and also support them to protect themselves. So the 35-year-old, those who are already in the reproductive stage, we are taking care of them through child spacing. These others also who are not ready to become parents, we are also taking care of them through giving them education and then giving them an opportunity to make a choice about what they want.
Asante. Sekunde 30. Kuna swala la sustainability tukizungumzia primary health care. Munalitekeleza vipi kuhakikisha haya mambo mawili yanaoana?
Kusema ukweli, there is a lot of political will. Hata ukiangalia Vice President amekuwa hapa, kuna pesa wametenga ya kustawilisha hii mpangilio. Lakini tunataka kusema pia hiyo isikue tu ya mara moja. Tuone kwamba serikali inatenga actually resources not from outside but internal resources from within generated in Kenya, because hawa wadhamini wanaweza ondoka wakati wowote. So wakiondoka basi itakuwaje? Halafu sisi wenye tunasaidia serikali pia kuna ile mpangilio. Tukileta ile program kama Pathfinder, tuna program hizi za kina mama, sexual reproductive health, tuko na maternal, newborn and child health, tuko pia na mambo ya afya ya uzazi na climate change. So hiyo iko kwa mpangilio ya serikali, na wengine wako na mipangilio tofauti. Tuone kwamba tuna ile fedha na ile mikakati tunaendesha iko katika the plan of the government. So we are talking about one plan, one strategy, one plan, implementation plan, and then the metrics ya measurement ikuwe moja. Hivyo sasa tutaweza kubolesha venye ile resources iko inatekelezwa. Tusikuwe na program inaitwa HIV, ingine inaitwa TB, ingine inaitwa SLH. So tukileta hizo resources pamoja, utaona itakuwa sawa.
Shukran sana Ruth Ongechu kwa kuzungumza nasi, na tutazidisha kuzungumzia hayo maswala.
Asante sana. Nashukuru.
Mtazamaji, huyo ni Ruth Ongechu ambaye ni mkurugenzi mkuu wa Pathfinder International, shirika ambalo limejikita kwa sana katika kuangazia afya, na si afya tu, kuna mengi ambayo yako kwenye afya, mojawapo ikiwa afya ya uzazi, mikakati mwafaka ambayo inafaa kuwekwa ili kuweza kufanikisha afya bora, na si bora tu afya. Mtazamaji, hivi sasa nataka nikupeleke kwenye mazungumzo ambayo yanaendelea katika uwanja huu wa Kapkatet. Washikadau mbalimbali wameweza kufika, wamekaa kitako kusikiliza wataalamu wa masuala ya afya wakizungumzia masuala ya yale maslahi ya wahudumu wa afya, na kuweza kuhakikisha kuna wahudumu wa afya wa kutosha ili kuweza kuhakikisha masuala ya afya yanaangaziwa kwa kina na kuweza kuboresha sekta hii ya afya, kwa sababu siku zote mimi husema kwamba afya ni jambo la muhimu sana, kwa sababu linatuhusu kwa njia moja au nyingine. Ukikosa kuwa na afya bora, basi mambo mengine kama maendeleo hayatafanyika. Hivi sasa tusikilize ni kipi kinajiri, kwa sababu waheshimiwa wale ambao wanatarajiwa hapa, waziri wa masuala ya huduma za umma ambaye ni Moses Kuria anatarajiwa kuwa papa hapa, ashafika. Vile vile Felix Koskei ambaye ni mkuu wa huduma za umma ama katika huduma kuu za serikali pia atakuwa katika ukumbi huu kuweza kuzungumzia masuala haya. Kwa sasa hebu tusikilize ni kipi kinaendelea katika uwanja huu wa Kapkatet. Baadaye tutakutaarifu zaidi. Wanakwetu wananiita Joash Onsare.
Terms of assigning and analyzing the needs that you are training for, and the answer is no. You look at it keenly, training and postgraduate training is individual driven. But if we continue in this trend, I think we'll not be addressing the gaps that we seriously have. Having said that, the counties have seriously supported all the doctors that have actually requested for post-training in terms of resources and the like. However, as a result of that, we see a little bit of a challenge in terms of impending successes and services to the so-called wananchi. An example in case is Nyeri County. Nyeri County has a total of 71 specialist doctors, where 41 have gone for post-training graduates. One of the things that we've been advancing with the national government is to have a formula on how to ensure replacement of those that go to advance their training so that there is no gap, there is no challenge that is left in terms of provision of quality service to wananchi. So I think this is something that is under discussion, and I think moving from these discussions, then we need to ask ourselves, if we continue this trend, what happens? However, we need to be alive to the fact that due to changing demands in this world, there has to be continuous training, retraining, and development of specialized doctors or health workers at the county level. Thanks.
Thank you, Madam CEO. And I like it that you highlighted that we need to train based on need. We just don't need to train for the sake of training. We need to do the needs assessment and then train based on the needs within our society or our counties. And I want to bring in Dr. Miskela and want to see if he agrees with you that that is the formula we need to adopt. And I would just want you to talk about the challenges facing the training, postgraduate training, and propose some of the solutions that we need to put in place to harmonize that area of postgraduate training as you introduce yourself. Thank you.
Thank you very much. I'm Dr. Dennis Miskela, the Deputy SG KMPDO, that's the Doctors Union. And first of all, I'd like to disagree with the CEO for COG that healthcare is not fully devolved. Healthcare is a shared function. That's why we have level 6 under the Ministry of Health. And the sooner we all realize that both national government and county have a conjoined role in making healthcare work, then we'll have the current challenges where any policy that comes from ministry, COG pushes away that healthcare is devolved. So that is the correction I have to make. Next to your question, on the issue around training, I think the biggest challenge we have around training of not just doctors, but all healthcare workers is that the training institutions in this country are under the Ministry of Education, except the KMTC. So you have universities being run under different ministry, the Commission of University Education coming up with courses and approving courses that are not needed for this market. A case in example, we have universities now offering degrees in clinical medicine. KMTC offers diploma in clinical medicine. When these two cadres graduate, they don't know whether to be called doctors or to be called clinicians. And sadly, as the parents, as these students go to school, they are made to believe that after school, they'll be able to get work. I even saw a university now offering a degree in ophthalmology. Ophthalmology is a subspecialist training in Kenya. Where will you take them after the graduation? So sooner or later, you're building this pool of doctors, of clinicians, of healthcare workers who do not fit in our current system. And that's why we urge the Ministry of Health and Education on matters of training, they have to come together to agree on the curriculum that makes sense. Because many times the universities introduce courses that will bring money to the universities. Secondly, on the issue of the cost. As you are all aware that as a doctor, when I go for school, I'm training to treat the patient. But when the university wakes up one day and triples the cost of specialist training, what are you saying? That in Kenya, only the few will afford it will do it. Yet we know every day that the disease pattern of this country right now, As we move into a middle-income economy, we no longer have to grapple with infectious disease. Cancer right now kills 80 people per day, yet we only have 100 oncologists in this country. Have we sat back to reinvent the wheel? Thirdly, as we even talk around training of the community health promoters, the idea about preventive healthcare being cheaper than curative healthcare is not just about giving deworming drugs or giving clean water and hand washing. Preventive medicine means that 50-year-old man can do PSA and detect prostate cancer early enough. That lady who has a lump on her breast can get FNA, histology, and get whatever the problem is. That young lady having a discharge can get pap smear done and diagnosis made. That is what preventive does. And it only comes when we train the healthcare workers appropriately for their needs and for the market. Thank you.
Thank you, Dr. Miskela. And you've mentioned community health promoters. I just want to bring our community health promoter from Ainamoi Community Health Unit to tell us what their role are and how are they prepared to serve within the community, to perform within the community. I think that in the area of community health promoters, we have had the discussions that they take the blood pressures, they take the blood sugars, and these are some of the things that even us, we have advised our patients in our own facilities, how to take their blood sugars and how to, when it is high, to refer them to the hospital. The same with the blood pressures. So I want to understand, how have you been prepared as community health promoters, and what are your role within community? In 2 minutes. Thank you.
Afya yetu, jukumu letu. Kwa majina naitwa Joyce Marandany, community health promoter from Ainamoi. Kazi yetu kwa kijiji ni mafunzo kwa jamii. Tunafundisha jamii na kutibu magonjwa madogo madogo. Mafunzo yetu sana sana hukua ya kwamba wamama waende kliniki zaidi ya mara 4 akiwa na mimba. Anapozaa apeleke mtoto kliniki. Mafunzo yetu ingine ni ya kwamba jamii zote wakuwe na choo inayotumika. Mafunzo ingine ni ya kwamba jamii wakunywe maji safi. Atibu maji ama achemshe maji kabla ya kukunywa. Mafunzo yetu ingine yenye tunapeana kwa jamii ni ya kwamba watu wakule chakula bora. Inastahili watu wakule aina yote ya chakula ili wapate afya. Afya yetu, jukumu letu. Kama volunteers tumefanya kazi muda mrefu kama volunteers, ambapo tumepata faida kwa sasa. At least community wametu recognize, na tunafurahi sana kwa sababu serikali imetu recognize. Going forward, at least watatu pea transport ya kufikia mgonjwa wetu. Kitu ingine yenye tumefurahia ya kwamba measures yetu ya magonjwa at least imeimprove, kwa sababu hakuna wenye magonjwa mengi yanayotoka na kukunywa maji chafu. Faida ingine ni ya kwamba at least our community health promoters watakuwa motivated na insurance, watakuwa covered. Tuko na challenges mbalimbali kama community health promoters because we are exposed to risks. Tunapo kuwa in contact.
Thank you. We are going to go into that in the second. Thank you. While still on this panel discussion, we are discussing the workforce production and development. And while still at it, I would want to spare my regulators for the last. But I want to ask our partner here, Peter Waithaka. They've been working with our institutions and with the Ministry of Health in supporting HRH development. One of the challenges that we have faced as a ministry is this discussion of when the healthcare workers goes for training, they still receive the payment, but they are not offering services at their counties where they are employed at. I want you to help us understand how are development partners supporting us in developing human resource for health and in the human resource for health production, and how can we then reduce the cost of loss during the training period. Peter, thank you.
Thank you so much, Daktari. My name is Peter Waithaka. with USAID. I'm the Human Resources for Health Specialist, and also undertake responsibilities for health system strengthening and also community health. 3 levels of trainings that development partners have worked on. And I'll start with the specialist training, where USAID actually, with the Ministry of Health, conducted an analysis on specialist training. And I'm glad the panelists ahead of me have talked about that. A situation whereby, from the analysis, it was very clear that when the specialists go for training, their salaries still continue being paid for by the counties, yet they're offering a service in another facility, say in Nairobi, where their training is happening. And so out of that analysis, the recommendation was, one of the recommendations is that can we have a collegiate system of training where the students don't have to go to University of Nairobi in Nairobi or another university where it is based, but they continue working, and then their trainers come to the counties to assess them and approve their levels of training, as it were. And that would call for more of engagement, ensuring we have adequate facilities within the counties, and also the trainers to be facilitated to come to the counties. And as such, counties will still benefit, still have the worker within the county, and as they continue training, because we still need these specialists. The other level of training that the development partners we have been working with, and at the Development Partners for Health in Kenya, is in-service training, where we have the continuing workers who need to be updated and to be developed. And from the analysis we have done, we have seen that most of these trainings actually happen in hotels and ad hoc places. And the recommendation that we came up with, can we have this institutionalized within, say, the KMTCs or the universities within, so that both the faculty there can be able to improve, and the resources available can improve the facilities there in as much as possible. The last level, the donors, development partners support a lot of training at the community level. And we are looking at it in terms of, can we have a regularized, standardized way so that the curriculum we use, all of us across the board, is the same, and we are able to ensure that our community health promoters actually, one in Mombasa, one in Turkana, actually are having a standardized way of being trained. Thank you, Dr. Ari. I'll leave it at that.
Thank you, Peter. And we appreciate the role of development partners in supporting us in training. I would want to ask Dr. Edna Talam about, is our healthcare workforce fit for purpose? But as you answer that, because you are the regulator, as you answer that, I would want you to also help us understand how can we streamline and standardize internship programs across all cadres. And I think the same question we'll also ask Dr. Kericho, who is the CEO of KMPDC, to also answer. Thank you.
Thanks so much. And quickly, by way of introduction, the councils regulate nursing and midwifery education and practice. And we are the biggest regulator in regards of regulating the health professionals. Parts of our programs and educations and the learning, most of what the conversation we've been having is competency-based training. Competency-based training ensures our health professionals are fit for their purpose. And it comes in 2 prongs. We have what it will be able to meet our local context. As you've heard from the trainers, they're able to engage the stakeholders, monitor the disease burdens. But there's much that we need to be able to do to ensure that we also match to the global best practice, because Kenya, we are pitching to be part of the medical tourism, and also to ensure that we meet the global market's demands, as we see that issues of immigrations are coming, reciprocal, and also transfer of the competencies. Back to the issue of internship. The basic purpose of internship is to ensure that we bridge the gap between theory and practice. And it's a formal inductions of our health professionals to the health systems that we have. And even in regards of how we are working and posting, we ensure that we post the interns across the country for them also to be inducted and to be mentored, even including issues like cultural competencies, and for them to be able to do that. So basing on the current model of the internship, a lot of challenges has happened in regards of planning, in regards of distributions, performance management, and even redesigning our programs to ensure that they are supported and clinical learning and teachings happen. And this is where we really need to be able to also review the competencies that they need to be able to work on while they are undertaking internship. Thank you.
Thank you. Dr. Kericho, please, you can.
Thank you. Dr. David Kericho, Registrar at the Kenya Medical Practitioners and Dentists Council. Basically, we exist to assure public health safety as we guide professionals when they are treating Kenyans across the country and across the world. I think one of the major things that we exist for is to ensure that we support the country in our journey towards universal health coverage. And the journey towards health coverage starts from the house to tertiary care for those who need it at some point. And in terms of training, we as a council have gone to introducing new ways of ensuring training for postgraduate studies, like was mentioned by colleagues previously, assessment by USAID, Waithaka's team. From that, we currently actually would want to inform that we have 51 centers across counties in the country training postgraduate doctors in surgery, in orthopedic surgery, obstetrics, gynecology, anesthesia, and the latest is actually the anesthesia and pediatrics. With that, there are many advantages both to the counties, to Kenyans, and to we as a council, as a regulator. One, the doctors now do not have to necessarily leave their home counties. They can be trained from there. With collegiate training, we, together with the training institutions or training facilities which are county-based, have agreed on a minimum set of infrastructure, human resource that should be attained for that center to continue being a collegiate training site. And I think with that, there's the benefit that Kenyans get with the increased infrastructure in terms of equipment for diagnosis, skilled service providers for the specialties that they are providing. Also, the doctors' families get to have their father or mother around them all the time, rather than them moving to other parts of the country. I think one of the key things is to have the minimum set of standards done.
Thank you. I would want to go back to the CEO of the COG. One of the challenges that is affecting development, or rather human resource development and distribution is the labor mobility, how you can move from one county to the next. If you, for example, during training, you are based in Moi, but then the training is over, you are now working in Nairobi. How then can we...
Kwa moja wakifika katika kituo hiki cha hospitali ya rufaa ya chuo kikuu cha Kenyatta kuweza kupata tathmini ni kipi ambacho kinajiri katika kituo hiki katika uwanja huu wa Kapkatet. Hivyo basi tunazidisha kukutaarifu tu yale ambayo yanajiri, tukisubiri viongozi hao kuweza kukaa na kuweza kuzungumzia masuala ya afya, huduma za afya na masuala ya wahudumu wa afya yote kwa pamoja, ili kuweza kuboresha afya kutoka afya msingi na kuweza kuiboresha kwa sana. Hivyo basi mtazamaji, sisi tuko ange kabisa na tunazidi kufuatilia hatua kwa hatua ili tukujuze ni kipi kitakuwa kinajiri na tujue ni kipi kinatarajiwa kuzungumzwa na viongozi hawa.
By doing so, we will not only be improving skills of the people that will require them in terms of specialized doctors, but also there will be passage and impart, skills to the other workers that are working within the facilities. And I think out of this conversation, this is one of the things that we should adopt as a way forward, that we need to decentralize training to the facilities so that we can be able to partake. And of course, this issue of doctors, specialized doctors going back to the national government to do training and offering the same services, while the county services are hampered as a result of that gap. I think this is one of the things that we need to undertake.
Zaidi.
Into devolution, and we thought that by this time we should have a policy in place to ensure that there is that mobility, and in terms of even transfers of skills. Right now, if you look at exactly what is happening, we have skills that lack in certain counties, but there is no policy on how to share the specialized, doctors across the counties. And I think out of these, I would propose that there must be a policy on how to ensure that we share the specialized, and we can't have enough, but we have to share. And for that reason, we need to have a policy on that. Equally, we must have actually adopt a policy just that there is at the national government, that employees can be transferred anywhere across the counties on need basis. And again, I say on need basis.
Kukujuza ni kipi kinajiri mubashara kupitia runinga hii ya TV 47 na tuweze kufahamu fika ni kipi ambacho kinajiri wakati wowote kutoka sasa. Hivyo basi tutazidisha
that we respect the functional assignment and resources as accompanying services that are so transferred to the counties. That way, we will be able to ensure that we live up to the standards of ensuring quality health for all. Thanks.
Thank you. Thank you. Thank you very much, Madam CEO, the CEO of Council of Governors. And I want to ask Dr. Miskela, as you give your parting shot, how then can we ensure to address the workforce distribution across these counties? How can we enhance specialist sharing as you give your parting shot in 1 minute? Thank you.
First of all, on the issue of decentralizing training, I'll not rush into that. Why? Because internship is a form of training, and the regulators will tell you that they are almost closing some internship centers. Why? Because they lack drugs, they lack requisite trainers, specialists to train. The easiest way to sort the problem in the short term is that anytime a healthcare worker is going back to train in Nairobi or wherever, their salary and school fees should be taken over by Ministry of Health to allow the county to fill the gap that has been left. Then when you graduate from your specialist training, then the ministry redistributes. Because currently I know of counties where we have more specialists than medical officers. My parting shot is this. After the dream of UHC, after you have bought the drugs, after you have put the digital health system, after you have built the hospital, after you have done all that, you must ensure you hire health workers to run the systems you have put in place. But more importantly is that the leadership and governance of it all, the county leadership, the ministry leadership must decide intentionally that they are going to put their money where their words are. So I hope that with this third launch of UHC, we are going to get it right both in human resource and in leadership and governance. Thank you.
Thank you. Thank you, Dr. Miskela. As you're aware, His Excellency the President prioritized human resource for health as one of the pillars of the UAC, and we are going to get it right this time. But I want to go to Kelly, who is one of the biggest producer of the middle cadres that meets our workforce demand within this country. Just help us in 1 minute, please, to understand how do we address the gap of needs versus production as you give your parting shot. Thank you.
Thank you, Hezron. KMTC has over 96 years of experience in training human resources for health. To address the gap between demand and supply, we work very closely with the counties. We involve the governors, we involve the CECs in charge of health, we involve the Ministry of Health to determine the need, and then we train as per the demand. As KMTC, we endeavor to produce the highest quality of human resources for health. We also want to request our governors and the ministry to consider employing the quality that we produce once they graduate. This year alone, we are going to graduate 22,691. We need to make sure that they are properly placed and that Kenyans are getting the quality of health care that they deserve. Thank you.
Thank you, Dr. Kelly. And I want to come to Prof. You are in academia. I would want you to, in 1 minute, help us understand, are the counties as currently is ready for decentralized training, and how can we enhance the communication or the efficiency between the Ministry of Education, which is the biggest producer of the workforce we consume, and the Ministry of Health, which is the consumer of this workforce? Prof, thank you.
Thank you very much. I think one thing I want to add is technology. The training of the collegiate system or training the postgraduate in the county. We have had what we call the Project Echo and use of technology where the students and the doctors in the counties are trained just where they are. And I think I see Senator Mandago here. We have discussed that a lot on how to train these people right where they are. And technology will help us, but we also have to be committed to UHC and the community health promoters. Thank you.
Thank you, Prof. The next question will not come from me, but I want it to come from Senator Mandago, who has a question, and then we address it in a minute. Senator, it will be easier.
Thank you very much. I have a question in relation to training, and it's good I see the regulators are here. KMTC is here. Prof is here from MTRH. Now, I've heard Dr. from KMPDU talk about the issue of training. I'm asking myself, KMTC has the capacity to train. Our universities have capacity to train. Why is MTRH training? Why is KNH as an hospital training? Why is KUTTRH as an hospital also training? Are we not creating unnecessary internal competition between institutions with different mandates? Why can't we allow the training institutions to run their mandates of training and allow the hospitals to run their mandate of clinical services and any other services within their mandate?
Thank you, Senator. This question I will give to two of our regulators here, and I will start with the KMPD CEO, Dr. David Kariuki.
Well, thank you very much, and thank you, Senator, for the question. I think training within health facility, especially a tertiary facility, is meant to be specific for the specialized services that they provide. Whereas the basic training facilities like offered by KMTC would be able to provide the masses critical numbers that we require across the country for primary level care services. It would be expected that the training occurring and being done by tertiary level facilities is specific to the tertiary services that they provide to be able to provide the tertiary level care that they would need, and especially that would not be available within the country, and yet they may have invested in technology that could be used. So they would be basically training for their internal or local use in the country for tertiary care services, so that each of the training institutions is conducting within a scope of certain service that they need to provide, and not necessarily training for, as an income generating activity. Maybe that's what I would say for now. Thank you.
Thank you. As Dr. Edna is preparing, I'm seeing the professor in the panel itching to respond. So I would want to give Professor Kimayo just 1 minute to respond to the question that Senator Mandago has asked. Why is it that the training the medical facilities have the task or the desire to train, while there are institutions mandated to offer training? Please clarify and help us understand this. Thank you.
Thank you very much. I think Senator Mandago really understands our MTRH College of Health Sciences, just next to Moi University College of Health Sciences. And I think the regulators said there are certain super specializations that KNH and MTRH and KUTTRH are very endowed to provide right there and consume that use right there. Super specialization. I know, Senator, you're talking about our, let's say, diploma nurses from these institutions. I agree with you on that. But the super specialization, the morticians, and so on, we need them, and they are best trained at these tertiary institutions. Thank you.
Well, it is, let's hear from Dr. Edna. I know your nurses are part of the workforce that are trained in both training institutions as well as these institutions mandated to offer medical care services. Please explain to Senator and to all of us here today why this is happening. Thank you.
Thank you so much, and thank you, Senator. This is a very good conversation, and we've had a bit of a dialogue that we need to be able to finalize. Yes, indeed, there is a bit of duplications of role, and we need to go back and review the legal mandates which establish our institutions, the legal notices, the laws, and the act. We've reviewed and we've actually noted part of our medical facilities which offers services. Within their laws, there are provisions of the training. We need to go back there and unpack what sort of the training and ensure that they provide the clinical teaching and support to the institution. And with that framework, we'll also work between, because we all fall within Ministry of Health. We have a common vision, we have a common outcome for us to produce the health professionals who are competent, but what colleagues have actually pointed out, to what extent do we have the super specialization and even supporting our KMTCs to do their role and leave our health facilities to be able to provide that clinical teaching, the clinical instruction and that. So it's a conversations and part of the declarations of health workforce planning, distribution, retention. Part of that, we should be able to ensure that within the next few months, we should be able to finalize and have a good transition plan to ensure that each institutions work within its own mandate. Thank you.
Thank you, Dr. Edna. And as Senator, you had our development partner here, USAID, encouraging collegiate training, which means we are going to be having this training within those institutions that you have highlighted. As he prepared to help us understand that better, as a specialist in HRH, I can see the union, KMPDU, itching to chime in and help us understand from the worker perspective, why is this happening? Thank you.
Senator, you have a good question. The only thing that medicine is apprenticeship kind of training. You learn by seeing and doing. So the hospitals, the MTRHs, the KNHs, the training must occur there because you can't just sit in class and learn the theory in KMTC. You must also be in the facility to learn by seeing the patient and treating as your seniors does. And that's why as a union, many a times we say that this idea that after internship, we dump the healthcare workers to go look for employment. We are doing a disservice. In medicine, the more you do, the more you learn, the better you become as a worker. So we challenge the government that maybe after internship, they can have a 2-year fixed contract, where after internship you stay in, learn the ropes, then when you are released to the market to go pursue your own endeavor, you are a better clinician for the public. Thank you.
Thank you, Dr. Miskel. I can see very many people are agreeing with you, and I know they'll give you a better handclap. But I want to bring Peter Waithaka, even as our Mary Marindany prepares to tell us how prepared they are as CHPs for this. This is going to be the last comment, and I want to have Peter just give a comment in 1 minute how this collegiate. We will end our panel discussion there.
Tuwakaribishe wageni wetu basi kwa makofi, shangwe na vigelegele tafadhali. One more time, tuwakaribishe wageni wetu waheshimiwa leo kwa shangwe, makofi na vigelegele. Karibuni sana. Kindly let us be upstanding for the national anthem. Let us remain upstanding for a word of prayer. I invite Ms. Lucy Kuria from KMTC to lead us with a word of prayer.
Let us pray. In the name of the Father, and the Son, and the Holy Spirit, amen. Our Heavenly Father, with humility we bow before you this morning, thanking you for your goodness, for your grace upon each one of us, and for your mercies that you renew every morning. We want to thank you, Lord, in a very special way for this gathering. That, Lord, as we begin this session, this day, being our third day as we celebrate towards our Mashujaa Day, that, Father, you are going to be with us in all the discussions that we are going to have, all the exhibitions, Lord, and all the activities of the day. In a special way, dear Lord, we bring before you our chief guest, all the other cabinet secretaries who are here, and all the dignitaries, our partners in the healthcare sector, all the players, and all of us as we participate in this great week, that, Father, you may enable us to reach out to those who need our care and our services in matters health, that at the end of it all, Lord, all the citizens of this country, Kenya, will be able to access affordable and quality health care. And above all, Lord, we continue to commit our President, His Excellency Dr. William Samoei Ruto, as he governs this country, that, Father, you may continue to give him wisdom, that at the end of it all glory and honor shall be upon your name. We pray all these, trusting and believing in the name of the Father, the Son, and the Holy Spirit. Amen.
Asante. Tumpigieni makofi tafadhali kwa maombi. Thank you so much. Head of Public Service, Honorable Felix Koske. CS Public Service Performance and Delivery Management, Honorable Moses Kuria. CS Health, Honorable Susan Nakumicha. All PSs present and all protocols observed, ladies and gentlemen. Good morning. Habari ya asubuhi. Basi tuwapigieni wageni wetu mheshimiwa makofi kwa kuja kujiunga nasi siku ya leo. Karibuni sana, and I'd like to take this opportunity to invite the chairman National Celebration, Mr. Dennis Itumbi, to take us through the next part of the program. Karibu sana, Bwana Dennis. Tupigieni waziri wa mayai makofi anapojiunga na sisi tafadhali.
The head of public service, CS is present, Excellency governors, MPs, senators, senior officials in government. Good morning. Good morning. Very good. Welcome to our third day, the third day of the Mashujaa celebrations. My name is Dennis Itumbi. I am the chair of the Mashujaa Thematic Committee. We are here to mark what has been the difference in national holidays, started in December last year by His Excellency the President, to redo our national holidays and how they look like. So we are here on our third day, and chief guests, for the last 2 days we have had intense discussions, and like you have seen as you went around, this country is prepared for the revolution. It is significant that the grounds of Kapkatet were chosen to host this particular conference, because on these grounds major decisions are made, and therefore this revolution was best made by being hosted here. Without wasting any more time, we are going to go right into the program, but before we do that, I will ask the ministry to give us a ribbon so that we can, it's also the National Breast Cancer Awareness Month, so if someone can give us a ribbon so that the chief guests can have the ribbon and we can go and pin the chief guest with a ribbon. Yes, Dr. Zuranira. But hiyo chief guest upatie dada moja ndio avalishe chief guest. Mr. Duranira, just give the, yeah. Please go and the chief guest next to the CS there. Just go there and pin. Professor Frank Wafula, please approach. Professor Frank Wafula, approach on the stage with the list of the panel, please. PS, please approach so that you can guide the rest of the program. Let's give her a round of applause for the PS as she comes. Let's go on until she gets on stage.
Thanks, Wazir. Sasa, Dennis. I'll simply invite Professor Wafula to open first. We open first. That's what we had said. Okay. So I don't know who will call next.
Just call.
Our chief guest, who is the head of public service, our CS, Madam Susan Nakumicha, the CS Public Service, Moses Kuria, senators present, our Deputy Governor, all protocols observed. Good morning. Good morning. Let me take this opportunity to welcome you to this third day of the UHC Afya Nyumbani Dialogue. Today has been purposed to provide the actors in the health workforce, human resource for health, landscape, and opportunity to honestly engage and highlight the real issues that affect our health workforce in order to realize our aspirations, and especially with the rollout of UHC. And the government of Kenya, through the Ministry of Health and other agencies, is really committed to offering this essential stewardship for the realization of the same. And because this is not being done alone, we are doing it together with the Council of Governors, the devolved systems of government. Health is a devolved unit. Therefore, the conversations that we will have today are going to be very, very essential. And with that, I would love to invite the chair of the Senate committee to come and give us some insights. First and foremost, he has been a governor in Uasin Gishu, so he understands the issues that are there in HRH, and he will be able to give us a few insights. Chair. A round of applause. Dakika moja.
Our chief guest, the head of public service, the Honorable CS, Cabinet Secretary for Health, the Cabinet Secretary for Public Service Management, and CS for PSM, sasa utazoea kumanage watu. Maybe you are used to goods, but now just get used to human beings. The PS, State Department of Medical Services, Harry Kimutai, PS Public Health, and PS for Agriculture. Thank you very much. Anyway, all protocols observed. I think that will be suffice. First and foremost, let me take this opportunity to say that as a nation, we are in the right direction in terms of matters health, and even in relooking our national celebrations so that they are themed to remind us as Kenyans of our aspirations and where we want to move as a nation. On matters health, we want to thank the national government and county governments, first, because for the first time, there is a very conducive and harmonious environment to discuss mothers' health in terms of responsibilities of each level of government, and also in addressing the so many challenges that we have had in the past when it comes to human resource management for health. Ladies and gentlemen, we all acknowledge that we have aspiration as a nation to roll out UHC, but without addressing the question of human resource, which will be the engine of rolling out UHC, then we shall have challenges going ahead. And I want to thank the unions for the dialogue they have had through the Human Resource Health Advisory Council, and we want to thank the chair and his team for the beautiful work they are doing. And we want to say that because of that entity, the Human Resource Advisory Council, that brings together county governments and national government, an institution that is deemed neutral to discuss matters between the two levels of government, we've seen a lot of progress. One of the challenges that exist, of course, is the shortage of health workers. But as we talk about shortage of health workers in our facilities at county level and national level, we must also admit that we have trained health workers who are not employed either at the county or at the national level. And that is the discussion we need to have going forward, that what shall we do to make sure that we have sufficient workforce. Training has been discussed, and I want to persuade the unions here, county governments and national government, that we have to be dynamic and realize that we have to live within our means. And we are willing to have this conversation as Senate Health Committee and Senate Committee for Labor in this question about trying to address the shortage of staff. Ladies and gentlemen, we know that it would have been good to employ all the health workers available in the country to meet the shortfall we have. But we also must admit that we don't have sufficient resources to recruit health workers, and that is why even today we are still trying to address the issue of UHC workers that were recruited on temporary basis by the national government, sent to county governments, the health workers who were recruited during COVID to support COVID response, and the Honorable CS, that team that helped this nation during COVID, when nobody was willing to go anywhere near a person that has been diagnosed with COVID, I think between national government and county governments, we must have a conversation on what we are going to do with those health workers. And in one way of rewarding them, counties and national government should actually absorb them. Those are the gallant soldiers, brave soldiers of this nation that put their lives for the sake of securing the health of the nation. So I would want to say that as we go forward, ladies and gentlemen, and particularly the unions and county governments and national government, we have to have a conversation. As much as we desire to recruit everybody on permanent and pensionable basis, we must create a framework where we can absorb some health workers, even if it is going to be on temporary basis as they proceed. Because I am a firm believer that training on health, and the Secretary General of KMPD was here, saying it is apprenticeship. So what happens to a nurse who has graduated from KMTC for the last 5 years and has not been employed anywhere? Are then the skills fading away? Why can't we keep these people in a working environment in terms that we can discuss and work on a framework where finally they will be absorbed as permanent and pensionable, or on a clear framework so that people know you can enter this position for 3 years because we don't have resources, you will serve at this level, you will earn this much, you will proceed. And we want to ask health workers to give government a chance to work on this framework so that you are absorbed. Because even when you are not working for government, sometimes you are working for other institutions, private facilities, private clinics, and so forth, earning far much less, probably what government would have offered on contract, although not P&P. So we want to have this conversation so that we can see how we can onboard as many health workers as possible so that we can address the issue of the gap. On the issue of training, Honorable CS, I know it's a subject that has been canvassed for a very long time, to the highest level, including the summit. I would want to urge the national government, through the Ministry of Health, and the CS, now Public Service Management, you are here. The responsibility of national government is training. Please, take the bill of training from county governments, train them at the specialized level, allow counties to recruit the fresh medical officers to fill in the gap, while the others train and specialize. Once you are through with the training, they can be redeployed back to counties and they will be absorbed everywhere in this nation, so that we are able to balance the needs at the county level, the need to have specialized officers to train so that we don't send our patients outside the country, and also make sure we are running a sustainable training and also service delivery for our counties and national government. So we really want to urge you to really deal with that. Finally, mothers training in terms of our training institutions, universities, KMTC, and the trainings happening in our health facilities. I asked a question here and I think it was not a bit very clear. My issue with this training, Honorable CS, is if we allow MTRH, for example, to train diploma in nursing, what will our KMTC be doing? They can do the specializations, and I understood Professor Kimayo very well, and we have worked very closely. But sometimes they need to train those highly specialized ICU nurses, renal, and so forth. We have no problem with that. But why are we seeing hospitals now deviating from their core mandate and beginning, to expand that function of training, while we have an institution whose sole mandate is actually training? So we need to regulate so that we know it is only on those specific trainings that then those facilities can be allowed to do, but allow these other institutions to be able to carry out with their mandate. If we do that, we should be able to succeed as a nation. And finally, let me say on community health promoters, and we want to thank this government, because that is where the rain began beating us on matters health. The moment we stopped focusing on primary health care, that is the time our expenditure for curative hit the roof. So community health promoters is the way to go. We understand that they will need training. I know some people say, these are not health workers, they have not been trained. Ladies and gentlemen, we must start somewhere. We cannot be, as a nation, waking up every 3-5 years and dreaming we want to roll out UHC, and we are not making the first step. So this is a bold step in the right direction in terms of rolling out UHC. And now we expect institutions like KMTC, the universities, MTRH, KNH, and others to begin now within their training programs to look at what is these short courses that can then be availed to community health promoters so that we can achieve what we want. But we must make the bold step. And I think this is the bold step that we are making. Congratulations, CS Health, for really standing firm and pushing to make sure that we have that first step towards UHC. So ladies and gentlemen, I don't want to say more than that. There are challenges, but we want to agree with the dialogue that has happened. Our unions, ourselves in the Senate, in the counties, and the CEO is here. Please, let's allow the National Health Advisory Council, as per the resolutions we are going to have today, let's give a chance to see whether we can have an harmonious working relationship between all institutions that are involved in healthcare management. Thank you very much, ladies and gentlemen. This is the right direction we are taking as a nation. Asanteni sana.
Thank you. Thank you so much. Chief Guest, the health workforce is one of the 4 pillars for the attainment of UHC at all levels, and that is why we are having this conversation today. The Ministry of Health devotes itself to having a highly qualified workforce trained in diverse healthcare fields to ensure continuum of care, including the community level. This ranges from defining policy direction on HRH, robust HRH planning, investments, including recruitment, supporting our acquisition of new knowledge, trainings and specialization to meet the population needs of our country. The ministry has invested finances in professional value addition activities aimed at boosting the know-how of our workforce. At this juncture, I wish to invite the chair of the Kenya Health Human Resources Advisory Council to come to the podium and take us through the panel discussion that is coming up. Dr. Wafula, kindly. Meanwhile, I wish to acknowledge my fellow PSs, my colleagues, starting with my colleague from the medical services. Please, wacha watu wakuone. Chief Guest, hii kazi tumefanya na PS Kimutai, hatujalala mpaka tuko na eye bags. My sister and friend, PS Duva, PS Public Service. PS Performance.
Specifically looking to discuss and
kindly.
Understand.
And my brother, Rono, PS Crops. Karibuni sana, and welcome to the conversation. Daktari.
Thank you very much, my PS Mary. Allow me to stand on the protocols that have been spelled out, because I've been given very little time to run this, and that's exactly what you're going to do. So we're going to be having a conversation about health workforce and labor dynamics. And I'm going to very quickly call my panelists, starting with Mheshimiwa Jackson Mandago. We need you back here to continue the conversation that you've started. He's a Senate Chair of Human Resource, Labor, and Social Development. Next, we have Madam Edith Okoki, the Director General of the National Employment Agency. Please, when I call you, just feel free to come up. Then we have Mr. Peterson Wachira, who's the Chair of the Kenya Union of Clinical Officers. Peterson, please come up. We have Dr. Mona Almudwani, who leads the World Health Organization Health Docket. We have Honorable Eric B., who is one of our own here. He's a member of County Assembly in Kericho, but more importantly, he's the chair of the Health Committee. So we'd like to get those views as well. And then I'd like Dr. Joyce Sitonik, who chairs the Human Resource Committee under the Kenya Healthcare Federation. And last but definitely not least, we have Ms. Joyce Marindanyi, who is a community health promoter. Thank you very much. Please.
Working very, very closely with our parent ministry, the Ministry of Health, and the Council of Governors, with very kind and generous support from the World Health Organization and the USAID office in Kenya, convened stakeholders in a two-day pre-national dialogue event, specifically looking to discuss and understand.
I think we can start. So I'll ask the video, just in the interest of time. Sorry to the members of the audience and the dignitaries. We did have a short 15-minute video that is a summary of 2 days of pre-dialogue that happened last week. So we wanted to play the 15 minutes in preparation for this dialogue. But we are a bit time constrained, so we'll ask for forgiveness. The video will play later, which means I'm going to beg your indulgence to move directly to the panel. And what you're going to do, again, just in the interest of saving time, you will say something about who you are very briefly as you respond to the first question, instead of having a separate round of introductions. I'm going to start with Peterson, and I'll give you 2 minutes. I know you are a unionist, possibly a politician in the making, but we have to control this. And the first question for you is, there's a lot of labor disharmony that we've witnessed over the last maybe 10 years or so of devolution. And we know that we need a unified approach to actually improve things. There are matters around CBAs, there are issues around contracts of staff, and then there are issues about promotions of staff. In just 2 minutes, Mr. Peterson, can you tell us how you think we can actually move towards resolving these challenges? Thank you.
Okay, thank you. Again, I'm Peterson Wachira. I am the National Chairman for Kenya Union of Clinical Officers. I'm also the Chair of the Health Union Caucus. Let me start by thanking you and congratulating the KHRAC, because I think this is the first time we are actually seeing a conversation that is bringing all of us together. And also congratulate you because I think you have been able to help us reach a consensus. And that is not a mean feat, especially when we as the unions are involved and looking at the interest of the members. Having said that, let me say that there are several issues that have been the pain points for health workers. Number one is the collective bargaining agreements. And the problem with the collective bargaining agreements has been that we are dealing with 48 employers. So sometimes, even as we blame the Salaries and Remuneration Commission, the frustration starts from when you have to deal with 48 separate employers, but you actually need to have one document, because according to the policies and the laws in place, you cannot have different terms for the same cadre. So what I think we have agreed in the declaration that we are going to make here is that just as it is provided under the Labor Relations Act, that the employers can be able to actually come together, probably it may be an association of employers, and then we can be negotiating the collective bargaining agreements with one entity, as opposed to then negotiating with the 47 counties and then the national government. So that is going to help us to probably shorten the time within which we negotiate. And I think we are an example as clinical officers. We have negotiated our CBA from 2019, which is way above the 4 years that have been provided for the CBA cycle. Now, coming to the second issue, the issue of engagement, employment. You know, we have so many varied contracts. We have the UHC from the national government, I think seconded to the counties. We have the county-based contracts. And within the counties themselves, and it's good that the former governor, who we have now recruited as a comrade, is here. You find that in a county, you have maybe contracts with 3 different terms. You have the same officer in the same rota doing the same work. One is at PNP, the other one is being paid a different salary, and the others who are even being called cashews and paid as cashews. This goes against the laws of the land. I think as per the provisions of the Public Service Commission Act, they say that you must be able to pay equally for work of equal value. And the other thing with contracts, we have, especially in county governments, where you find them renewing contracts more than once. And the law provides that you cannot renew a contract more than once, which in legal terms would be inferred, permanent and pensionable if you are going to renew more than once. And lastly, we have the issues of promotions and redesignation. And you know, motivation for health workers is not just about the money. Sometimes this motivation you get from promotion. We have officers who are employed and you have worked for 30 years, you have only been promoted once or twice. We have officers who have gone back to school, they have specialized, they have increased on their skills, but when they come back, they are not redesignated. Some of them are even running into medical legal issues because you have learned a new skill, you have not been redesignated. When you perform that procedure and then you are taken to court, actually the court calls you a masquerader because whatever is provided in your job group as corresponds to the job description in the scheme of service is not what you are practicing. And so if you have a procedure that is botched, you can actually go to jail. So that underpins the importance of ensuring as a motivation that we fast track the issues of promotions and redesignations. And I'm happy that we have been able to agree on modalities to ensure that this happens. Thank you.
Thank you very much, Peterson. Yeah, so you've actually raised 3 very important matters that I'm going to spend a bit of time talking to the other panelists about. And Mheshimiwa B, nice meeting you. I just met you today. We've had a very good conversation. As a member of County Assembly, nyindo mko kwa ground, if I may use that phrase. Can you respond to that? Are you just refusing to promote people? Do you have the money? What are the challenges that you face when it comes to some of the issues that Peterson has raised, and how can we help?
Thank you, Daktari. Before then, allow me to welcome all the visitors on behalf of all the leaders within Kericho County. As my name as you heard, I'm Honorable Eric B., an MCA representing great people of Kablil and Chair held in Kericho County. Daktari, The issue of promotion, I must begin with, if we want to implement universal health coverage, we must have policies in place. So with the issue of promotion and confirmation, I must inform these people that we have budget constraints. When we have issues of resource allocation, we've been guided by the BFM Act, and also at the same time we have an SRC advisory, whereby in development aspect, we are dealing with 70%. And when we come to recurrent, we are having a challenge of less than 30%. So I must say that as a county government, we have challenges because the resource allocation, the issue of money follow functions. We've been having challenges. Of course, as my colleague has said, that we have issues with the medic who are in contracts and some are in permanent pensionable. There is a discrepancies between the same. If a health worker is working as a nurse who is earning less money and they're working in the same environment, it is a bit challenging, and I must confirm that we are working hard. As a county, we have been having a push and pull from the department that we must sacrifice some other aspects so that we confirm nurses and medic who are in contract basis. And to our information, today, His Excellency the Governor, Dr. Mutai, really confirmed to us when we were opening this session, and he said that as going forward, Kericho County will be able to confirm all those medic who are in contractual basis.
Mheshimiwa, sorry to interrupt you. Do you have a timeline for that? Because we are very keen on solutions.
Thank you very much. His Excellency Dr. Mutai actually confirmed. He really confirmed to us that he's going to confirm putting up the Hartford before the Mashujade, that is on Friday. So I must confirm that where I sit as a chair, we have already allocated some money for the same 1,050 medic who are in contract, and we are going to confirm. I confirm also that the period is unconfirmed.
That is really good news. I'm going to cut you short there, and I'm putting you in the spotlight, Mheshimiwa. There are some people who are going to be confirmed in Kericho County, and KHRAC is going to follow up and see that that is done with Mheshimiwa. I'll come back to you, Mheshimiwa, if you allow me. I just want to very quickly, because this is related to what Mheshimiwa Mandago said earlier, but now I'm going to ask you something slightly different. Are we fighting over a small piece of bread? Should we be increasing the size of the pie? How can we, as a health sector, get more resources to deal with these ceilings, budget ceilings and challenges at the county? In 2 minutes, Mheshimiwa.
Thank you very much, Chair. The first thing that we have done as the legislature is actually to pass the additional allocation bill and also conditional allocation. Now, that is getting additional resources to counties to make sure that they are able to run their services. Now, going forward, what needs to happen in order to increase specific funds going to health, through the facility improvement financing bill, we now need to send funds directly to those facilities, or send money meant for health that is now ring-fenced within those pieces of legislation to make sure it is not spent on something else. You know, the challenge we have, and exists in counties and even national government, is the competition for the scarce resources. But we must be deliberate as a nation that one of the key things we want to achieve is to make sure that our people are healthy. And when people are healthy, they'll be more productive. That means there will be more taxes to be collected from a health workforce. So in order to create that, the 3-4 pieces of legislation that have been passed is going to enable counties, is going to enable national government, development partners, send money ring-fence specifically for health. And of course, we shall continue urging national government to increase allocation to counties. But as we increase, we want the money for health ring-fence for health, so that when they arrive at the county, members of county assembly can only appropriate within the health function and not take that money to other functions.
Thank you very much. I think we can all clap for that. I want to come to you, Dr. Mona. Even as we talk about money and priority setting within counties, do we have a problem between demand and need? And how can we address that so that we actually get that balance right as a country?
Thank you so much. Yes, definitely we have a problem, but it's not that serious because I want to congratulate Kenya because the labor market analysis have showed that Kenya has doubled its training by the last 10 years. So doubling the production in the last 10 years is really a milestone. However, the same analysis have shown that there is still a gap at the front line if we want to achieve UHC. So to address that, WHO recommends that there must be a kind of discussions. I mean, this dialogue is a very big first step. But what we are suggesting, if the country can plan for an annual meeting between education, health, counties, of course, to discuss, first of all, what are the numbers that we need to produce and what makes each year? What are the employment needs and where should we deploy them? And then discuss with counties how to distribute them, especially for counties that have shortage in labor, in health workers. In addition, we need to develop an investment recruitment plan looking at, this is what WHO recommends, between 7 to 11% increase in budget annually to be able to absorb the newly recruited health staff. So it's really practical steps, but incremental, that if we adopt, we can really reach some improvement.
Thank you very much, Dr. Mona. We are spending too much time talking theory. So I want to come to you, Joyce, Madam Joyce Marindani. You are a community health promoter, and you are proud of it. This has been your week, and it's going to continue being your week. You've listened to all this conversation. What are your feelings about the new model that is being put out, which includes some compensation, kitting, and a plan to develop community health promoters? Just in 2 minutes, what is your view on that, as somebody who stays in Kericho and is doing that?
My name is Joyce Marindany, the chairperson for the community health promoters from Ainamoi. I'm happy because we have been given stipend and the tools. We are happy for the tools because we will work hard and ensuring that UHC is successful. Thank you.
All right, thank you. And you're very brief. I think a lot of us could really learn from you, Joyce. I'm very wordy particularly. Another Joyce, Dr. Joyce, the private sector, how does the private sector come in? I know one of the concerns that keeps coming up is we make a lot of policy, but it's never quite clear where the private sector comes in, particularly with regard to information. You chair the private sector Human Resource for Health Committee. What are your feelings as a private sector on how you can support this direction by government?
Okay, thank you, Prof. And really pleased to be here as part of this discussion as private sector, recognizing the huge responsibility that the national and county governments have towards ensuring health for their citizenship. Our role is largely complementary. We are finding our space in the primary care networks and could potentially be some of the sponsors for the community health volunteers and promoters. The other thing is our membership actually covers the entire value chain of healthcare, right from service provision to medical devices, IT, and other monitoring partners. So providing devices or innovation on devices that can improve the ability of the community health promoters to track and screen some of the high-risk patients as well as report. Beyond that, we have developed centers of excellence amongst our membership. The hospitals that are centers of excellence around pediatric care, cardiology, oncology, which are actually being onboarded into the collegiate training, as mentioned earlier by the by the CEO of the Kenya Medical Practitioners and Dentists Council. Recent additions to the surgical collegiate training, like on-the-job training, to name a few, like the Metropolitan Hospital and the Avenue Hospital, etc., and many of them are coming up. Lastly, and one of the feedback we've been getting from the Ministry of Health and KHRAC is there is some level of lack of data from the private sector as far as the healthcare workers that are working with us are concerned. 30 to 50% of our operating costs actually go to paying salaries, which then shows that the healthcare worker is a significant factor in our operations in the private sector. And it is end-to-end, beyond the facilities to manufacturing to leveraging IT, developing artificial intelligence to assist with the diagnosis and management. Yeah. Okay. So we are working with the KHRAC to improve reporting of the healthcare workers that are within the private sector. Thank you.
Yeah, thank you very much. Yeah, and that's really crucial because quite often we have a lot of information but from the public sector. It's very hard to do planning without reliable information from the private sector. Last but not least, we've talked about production of human resource. We talked about labor dynamics and employment and matters of much of need and demand. I'm going to call on the Director General of the National Employment Agency, Ms. Heath Okoki. We are accused of sending our healthcare workers to serve abroad when we don't have enough here. There's a lot of myth and conversations going on around the bilateral labor agreements and the staff going to other countries. I just need you in 2 minutes to maybe help the audience understand this a bit more and explain to us what you see as success stories and challenges. Thank you.
Thank you. As you've heard, my name is Heath Okoki. I work with the National Employment Authority as the CEO. Labor mobility is as old as mankind. You cannot stop human beings from moving and seeking employment or pastures elsewhere. As usual, government always comes last when people have already moved. And in that manner, we felt because of the very many Kenyans that are going out there for employment, that we needed to have bilateral labor agreements. In short, we call them the BLAs. And these BLAs have emerged as a very important instrument in the protection of the migrant workers. And they can come in different forms. We have them either as MOUs or even as bilateral or multilateral agreements that governments then do have. Now, the importance of having these bilateral labor agreements is so that we can have protection of the Kenyans who go to work in those countries. This is an instrument where the two governments can come and agree on the working conditions, on the pay structures that they will have, and more specifically on the protection of workers. Yes, we are having very many health workers moving out there, but what we are having as an arrangement on the BLAs is so that the receiving governments can then maybe improve the training in the countries where they are getting the health workers. So yes, BLAs are very important. Thank you.
Okay, thank you very much. Unfortunately, due to time, and you saw my PS coming to whisper to me, we will actually not have a second round of questions. I really apologize, but I want us to do an exercise. Just breathe, just breathe normally, I want you to inhale, and then with one exhalation, I want you to give your closing remarks. When you run out of breath, it ends there. And here is my request. What is the one thing you desire to see to make human resources work for health? I'm going to demonstrate. I'm going to inhale. I would like to see a mechanism in place that allows our healthcare workers to have the opportunity to move from one county to another or from national to county level, just so that they can be with their families. I'm out of breath. We are going to start with Dr. Mona, just to change the order. Inhale, exhale.
Okay, I want to see the Kenyan health workers interested to work in their own country. They have the incentives and they have all that it takes for them to really not to want to migrate and to work in their own country.
Oh, you're very good at holding air. Good. Dr. Joyce?
My wish or hope is that we have a collaborative approach between the public sector and private sector to leverage on our human resource for health, talent, as well as other strengths. Thank you.
Thank you, Joyce. Joyce B.
As CHPs, we need more training. We need more support from the government.
Thank you, Joyce.
Thank you, as our Chair Health. I'm looking forward for resource allocation, increased resource allocation from the national government to the county assembly, to the county government, so that we can move on with the health care services within this county. Thank you.
Thank you, Mheshimiwa. Peterson.
Yeah, thank you. I think for me, I'll say 3 P's. People, process, progress. Take care of the people, that is the healthcare workers. They will take care of the process, and you're going to see progress. Thank you.
Thank you, Peterson. Madam Makoki.
Yeah, for me is to have a platform where we can have our health workers, even if they want to stay in the countries where they've gone to work, they are given an opportunity to have short-term consultancies so that we can benefit from the high skills that they receive in the countries they go. Thank you.
Thank you, Madam DG. And last but definitely not least, Senator, let's see how much you can hold your breath.
A politician is unlikely to hold breath. But let me say that what I would like to see myself is a legal framework that will enable county and national government on board more health workers into the system to support the rollout of UHC within the available little resources we have in the country. And every player giving a chance to this government, to the Ministry of Health, to county governments to roll out this UHC and supporting it to make sure it succeeds.
Thank you very much, Mheshimiwa. Please give the panelists one more round of applause. Clearly, we have super talent when it comes to holding our breath. I think I've managed to keep this within the time, actually with 1 minute to spare. So thank you very much, and we look forward to more engagement. I'm going to hand this back to my peers.
Another round of applause as they step down. Endelea kuwapigia makofi jameni. Hey. Thank you very much. Ladies and gentlemen, afya yako ni jukumu lako. Afya yako? Afya yako? Jukumu lako? Jukumu lako? Afya yako? Now, I want just 1-2 responses from the crowd. Anybody who has a question, a comment, this is your time. I can see the hand there. Where are the mics?
Thank you, honorable peers and all protocols observed. My name's Brown Ashira. I'm the Secretary General for Public Health Union, and I want to appreciate all the panelists and what they have done so far. But I want to request going forward that we make sure that we incorporate both curative and preventive together, that we speak in one language. PHC is traditionally a community-based approach, and we have cadre like public health officers and technicians who are actually implementing those cadres, and we are happy that we are on the table. Thank you, and God bless you. Asante.
Thank you so much. One more person. There's a hand here. And Simon from PSC, I would have wished to hear a word from you.
Thank you very much.
Yes. Go
I'm grateful for this conversation. My name is Beatrice Cairo from Fred Wallace Foundation. We've discussed so much about human resource, but we forget that once they are trained and we have human resource, do we have the equipment and capacity in our hospitals? That even in the dialogue and even in the final drafting was not really captured, because it's key, because most of these skills are lost when you've deployed that doctor in the county facility, but when you go to the county facility, they don't have the equipment to be able to utilize their skills. So I think that should go hand in hand. As much as we're discussing human resource, let's go hand in hand with the equipment. Thank you.
Thank you so much. I want to bring to the attention of the delegates that we have done an assessment of all the hospitals in the country, all the health facilities, more than 14,000 of them. We have the report, and we are going to launch it soon. That will give us the gaps that you're talking about, gaps in terms of equipment, in terms of human resources, and it will also help us to plan better. So I hope it is answered. Thank you so much. At this juncture, maybe we can stand. Oh, we have a question?
Yes. I think one of the issues we are seeking is to have industrial harmony. How do we have harmonized terms of engagement for healthcare workers? Because that's one of the biggest issues that we have in the sector.
Thank you so much. How do we have harmonized way of operation? And the last one. Somebody can capture those questions.
Dr. Simon Kigondu, Kenya Medical Association President. And, on human resources, I think we are doing well. We want to thank the organizers for the meeting, but I think we need to depoliticize health workers and also delink health workforce from resources. Mandago, thank you very much for the comments. Maybe we need to say that the health output is this, but we don't have finances. How do you cover that gap? And all in all, I think we need a health service commission.
Thank you very much.
Thank you very much. I'll make it very short. And I'm asking this because the head of public service is here. Our beloved government promised us to hire 20,000 healthcare workers. Is there a plan to hire 20,000 healthcare workers as promised? Thank you.
Thank you for your question. And the very last one. Is that KMTC? Okay. I would have wished to hear somebody from KMTC say something. Our ladies and gentlemen in KMTC, I'll give you the chance. Good. Come. Yes.
So, thank you very much. Dr. Mwirigi Kiula, Deputy Director, ICT and Innovation at Kenyatta University Teaching, Referral and Research Hospital. I have had the discussion about healthcare workforce. In an increasingly digitalized healthcare workforce, there is one healthcare worker that you are not talking about yet. That is the ICT practitioner who is sitting behind your servers, your data centers, your cables and everything. When will the ICT practitioner be considered a part of the healthcare workforce? Thank you.
Thank you. Asante. Rome was not built in a day. We are just starting. Hii boat ni yetu sisi wote. Tunasonga mbele. Nataka maiki yangu.
Yes. My name is Okinyi Omondi Nixon. I'm a student from KMTC. First of all, I would like to take this opportunity to say a big thank you to our president for this opportunity. And a big thank you to in promoting universal healthcare. Our request is, back in the village, we really long to do these courses, but the problem is financial. We are coming, we enroll, and all of a sudden you find we defer, and even some who are out, who have done these courses, we will request the government so that they be absorbed. Thank you very much.
Thank you. Thank you. Has somebody captured the questions? I am sure as we continue to have the guests speak, we will continue answering those questions. And because of time, I want all of us to stand, stretch. You know, Kisumu is taken to be up here because it's in the western side. Ukikuja Nairobi, unaweza fika katikati ya mwili, na Mombasa inakuanga pale chini. So when I mention one of those cities, you make sure you touch where I've said. So if I say Kisumu, help me. Kisumu, Nairobi, Mombasa. Kisumu, Nairobi, Mombasa. Nairobi, Mombasa, ogelea na ukae chini. So at this juncture, I want to invite Dr. Wangia to take us through a panel discussion on health financing. Please. As I leave the stage, I want you to invite the panelists, and at the same time, you invite Dr. Mwai, who you're going to give the mic first to set the tone for that panel. Thank you.
Thank you so much, PS, and all protocols observed. My name is Dr. Elizabeth Wangia, the Acting Director, Health Financing, State Department for Medical Services, Ministry of Health. My role is quite simple at this point in time. I'll go straight to inviting Dr. Daniel Mwai, who will take us through health financing reforms for affordable, equitable, and quality care for all Kenyans. A bit of profile for Dr. Mwai. Dr. Mwai is a health finance specialist with a wealth of experience and expertise in the field of health economics. He holds a PhD in health economics from the University of Nairobi. He currently serves as the advisor to the Presidential Economic Transformation Team on Health and holds the position of senior lecturer in health economics at the University of Nairobi. Dr. Mwai is also an integral part of Future's Health Economic and Metrics and renowned consulting firm that specializes in providing evidence-based solutions for global health investment. I would like to welcome Dr. Mwai with a round of applause.
I am talking or I'm sitting down? I first sit down.
Okay, thank you, I'm guided. So, Dr. Mwai, kindly take your seat. The next panelist we'll have on board is none other than our Director General for Health in Kenya, Dr. Patrick Amoth. Dr. Amoth is the Acting Director General for Health. Presently, Dr. Amoth chairs the World Health Organization's Executive Board. Before this role, he led the Directorate of Public Health formulating strategies for the efficient delivery of health services across the 47 counties. His leadership also spanned the Department of Health Sector Coordination and Intergovernmental Affairs. Dr. Amoth's trajectory in the civil service is marked by steady progression. He holds a bachelor in medicine and surgery and a master in obstetrics and gynecology, both from the University of Nairobi. Dr. Amoth also has a diploma in health management from Galilee College, Israel. Our next panelist is Robert Rapando from the Council of Governors. Robert Rapando from the Council of Governors, who is a health system specialist. Our next panelist, Robert Rapando. Our next panelist will be Ms. Jane Ngugi. Jane Ngugi currently serves as the private sector engagement specialist in health insurance and health financing at USAID. Karibu, Jane. The next on the stage will be Dr. Doris Kirigia. Dr. Doris Kirigia currently holds the position of team lead for social determinants of health in the Healthier Population Cluster of the Afro-Regional Office of the World Health Organization. Our next panelist will be Dr. David Haoya. Dr. David Haoya currently serves as the country director of Propel Kenya for USAID. He's skilled in qualitative research, development economics, health, and health economics. Currently working as the Deputy Director, Technical Health Policy Plus Project. Mic check. I hope your mics are working. I'm feeling you can come closer. So thank you very much. Our first question, panel question, goes to none other than our Director General for Health, Dr. Patrick Amoth. Dr. Amoth, several health reforms are ongoing in Kenya, especially in the health financing, and conversations on social health authority. How is a Kenyan and the entire health system envisions to benefit from these reforms?
Thank you, Dr. Wangia. Health financing is critical for achievement of universal health coverage, and therefore to be able to have a sustainable health financing platform then means people can be able to access healthcare services. For a long time, we have tended to fund curative health services. And now the paradigm shift that we have is to refocus more on preventive promotive health care. And the Social Health Authority will come in as the main platform for strategic pooling and purchasing of healthcare services. This will ensure that we have a bigger pool and therefore reduce the risks that will be suffered by the authority when we deliver healthcare services. Number two, the Social Health Authority, again, will also ensure that we have a prepaid mechanism for funding healthcare system, therefore avoiding the unpredictable out-of-pocket expenditure that Kenyans face each and every day when they go to seek healthcare services. And importantly, and number three, is that the Social Health Authority will also ensure cross-subsidization. This is where then the rich will support the poor, then the healthy young people will be able to support the elderly who are likely to seek healthcare services. And then those who are healthy and pay their premiums, again, will also be able to support those who are sick with chronic illnesses. So that is one area where the Social Health Insurance Authority will come in to be able to change how we pool our resources and protect us from the current scenario of adverse selection, where you go and pay a premium for 3, 4, 5 months. Then you go to NHIF, I have a kidney problem and I need to go to India for kidney transplant. You are paid a premium of 3,000 shillings, and NHIF, when you go for transplant, is going to pay more than 500,000 shillings. That is not sustainable in the long term. Therefore, these changes will make sure that we have a bigger cake to be able to draw from and ensure the protection of everybody as we seek healthcare services. Thank you.
So thank you so much. What I hear from you is that we need to, the Social Health Authority basically will be looking at how we pool resources and also the issues relating to cross-subsidization. The next question will go to Dr. Kirigia, just tying up with what DG said. And this, DG talked about prepayment mechanisms, and he also talked about pooling resources. And from you as WHO with your great specialty, what are the key considerations that need to be put in place when identifying the informal sector for social health insurance? We know as a country, the informal sector caters for 80% of the, of the people in the society. 80% is informal sector, and it has been a challenge really targeting this informal sector. And you have told us, we know that with the Social Health Authority, our main focus will be to target this 80% of the community. So what I'm asking is, what are these key considerations when it comes to identifying the informal sector for social health insurance and determining their ability to pay? We have been asked, how much will they pay? Probably you can pick up on that.
Thank you very much, Dr. Wagia. And that's a very important question, I think, that everyone is asking about. First, we commend the country moving towards social health insurance scheme, and we have to emphasize the need to ensure that each citizen is able to pay something that is commensurate with their ability to pay. So it is very, very important for us to estimate what each household is able to afford. And by doing so, it is by supporting the country to undertake what we call proxy mean testing to be able to ascertain that. And we are happy to report that the data that is being collected by the community health workers will go a long way in helping that, because it is real-time data, it is disaggregated, and it will be able to be used using complex statistical analysis. And I have to emphasize here that indeed Kenya, unlike many countries, the population that is in informal sector is about 80%. Then we also need to think about the 40% that are classified as poor households. So those are some of the considerations that we have to make. And so the mean testing, it works by scoring each household according to the level of poverty and richness. And by doing so, it is using statistical analysis, as I said, that will be able to help us undertake that analysis. In this case, the classification works from number 1 to 5 in terms of classification. And so number 1 and 2 are populations that are not doing extremely well, are disadvantaged population. And those are the populations that the government will be able to subsidize when it comes to premiums. But also, let's not assume that the informal sector are not able to pay, because majority are doing, they are involved in enterprises, they're able to generate resources, and they're able to pay. So it is important that we undertake the assessment to establish the ability for households to be able to pay. I don't know whether I should take you through the statistical analysis, or I stop here for now.
No, I think that's clear. Yes. And as you say, we cannot say that we have achieved UHC without thinking of equity. And mainly when you're looking at equity, you're mainly looking at the vulnerability, people who are vulnerable. And you correctly say that when you do the proxy means testing, there'll be a banding between 1 to 5, of which 1 and 2 will mainly be for those who are really poor, of whom the government will subsidize. Then from band 3 to 5, people will pay according to their ability to pay. So thank you for that. My next question goes to Dr. David Haoya, and this is, the question is on, still on the social health insurance. So despite being common in other countries, mandatory social health insurance is relatively new in this country. What do Kenyans need to know about social health insurance, and what does Kenya stand to gain by adopting a social health insurance model?
Yes, thank you, Chair. My name, as you've been told, is Dr. David Haoya. I'm an economist by profession, and so I want to look at these things from first a theoretical angle before we see how we are able to implement. First is a social health insurance mechanism has 3 major characteristics. One is that it relies on compulsory contributions. That is very critical. 2, it's normally managed through an independent or quasi-independent fund. And also that is also critical because of the involvement of many other stakeholders who may want to have an independent mechanism to work with. And then 3, there is a clear link between what people contribute and the entitlement they get out of that. Now, having said that, what are these benefits that people get when we have compulsory payment? Is because on your own, paying for a medical bill may be very expensive. But because everybody is paying through compulsory contributions, all of us are now able to afford through that mechanism to be able to offset our bills. Secondly, social health insurance, like any other insurance mechanism, smoothens people's consumption over time. And that is important because you can imagine a mama mboga who has a plan to do some investment and gets worried about the types of health risks in between the life of their life. So through social health insurance, there is smoothening, and so this mama mboga does not mean, or rather does not need to worry about paying for high bills whenever they come through. And then, of course, more importantly, is that it solves the problem of adverse selection, as Dr. Abad has said, because of the fact that people do not just pay for purposes of using, because everybody is paying, and so there will be no need for us to deal with issues of adverse selection. Thank you.
Thank you so much. I hear a lot about cross-subsidization. DG talked about the same. I'll hand over the next question to Ms. Jane Ngugi. Jane Ngugi has some experience in onboarding the informal sector through the use of cooperatives. And this question goes to her. On onboarding the informal sector into health insurance, when onboarding the informal sector into health insurance has been a challenge in the country, as we have all discussed by the previous panelists. When they enroll, there is adverse selection and low retention. How can cooperatives be used to increase enrollments and retention of Kenyans in the informal sector into health insurance?
Thank you very much, Dr. Wangia. I think it's very evident that the informal sector, as you said, represents 83% of the employment based in Kenya, and therefore forms a very big proportion that needs to be on the table in terms of insurance, universal health coverage. So this informal sector, Mamboga, the Uber driver, the coffee farmer, the tea farmer, we're in Kericho, the dairy farmer, and when hit by a health shock, they will sell that asset. And unfortunately, that affects every other of their business. So that U.S. Agency for International Development, together with the Ministry of Health, we co-created partnership model of engaging the cooperative sector. We know the cooperative is very vast in Kenya, cuts across all sectors, be it agriculture, be it transport, and therefore we develop a partnership approach that had two solutions. So we were looking at overcoming 4 barriers. And the 4 barriers are the cost barrier, the financing barrier, the administrative barrier, the communication barrier, and the information asymmetry. And we used 2 prongs. We developed a champion training toolkit that the cooperatives could adopt. And the case in point here which we used was KTDA. So KTDA, as at 1st of March, there were only 110 members in NHIF. So we trained their own champions who understands them and used a listening approach to see how health needs can be met and channeled them through NHIF. The other solution we provided was an insurance premium financing for them. It is very hard for someone who earns very little daily or gets the money twice a year when they have to sell their crop. So we standardized that by premium financing them, so cooperatives would pay on their behalf and deduct across the year in a very affordable way. And that matches with the government of Kenya's mandate to ensure that there is an affordable and a flexible method of paying premium for the informal sector. So the other way we did it is we used their own. We used the T extension service assistants and trained them on the NHIF, the benefits of NHIF. So we believe this model is good because it brought 2 results. Number 1, we increased the membership in only 3 months to 1,000 and an additional premium of 3.6 million to NHIF. So when we transition to social health insurance, this is a fantastic model and a game changer to reach the informal sector. And we believe that this training toolkit could be also adopted by the community health promoters, and this model could feed into the regulations that are going to operationalize the social health insurance. Thank you.
So thank you so much, Jen. I think that is the kind of innovation that we need moving forward. So over to you, Dr. Mwai, to seal everything up. You are the President's advisor on health. We have been championing together the social health insurance and general health financing, which is a key priority under the BETA agenda. So as you, I would like to welcome you to just seal everything up. Tell us what will happen after tomorrow. Tomorrow, the expectation is that the President will be assenting the bills, and that's when the work will start. After tomorrow, how do we get into onboarding? How will we determine the ability to pay? How will we use innovation such as what has been discussed here in terms of premium financing to have, a sustainable financing for health in the wake of donor transition?
Thank you very much, and good afternoon, everyone. I wish I can stand because a lecturer is always used to standing, So when I sit, I feel a little bit constrained. So I think I want to highlight some few things about the reform agenda. One is that this country have come a long way since the 1965 on issues of healthcare financing. And we know that towards the last years of the 2003, when we had the healthcare financing strategy close to being assented, but the political class then did not do it. And of course, the main reason was the fact how will it be sustainably financed? And then the President did not assent the bill, even if it had gone through the Parliament. The second attempt, of course, came 2022. We had a revision of the NHIF Act 2022. Which ideally did not address the issues that are critical in financing for health. And now we are in 2023 putting a third, actually I counted, it's almost the 6th time when we are trying to do a change to ideally finance healthcare. So within the government thinking as of now is that Kenya's economy has changed, transformed from largely a formal to an informal system, what we call non-payroll people instead of the payroll people. But the social insurance that we have founded this country for the longest is only centered on the employed. And these employed, ladies and gentlemen, are only 20% to the maximum. Now with that then, it means that if we have to sustainably finance care with that mechanism, then we need each household to carry another 4. So that now you have 20 times 4 is 80 plus yourself. So you carry 5 households. With a household size of 5 people, then it's 25. So each contributor ideally should carry almost 25 individuals. That is impossible. Numbers do not lie many times, but people lie with the numbers. So we have for sure been trying to find a pathway using the long route, which does not give us the result. Now, the reform agenda, and this is what is included within our bills that have gone through the House. Thank you very much, Waheshimiwas, for good work. These are bills that are starting to realize that 80% are the Kenyans, and the 20 are still Kenyans, but they are the fewer. So how do we come up with a healthcare system that is financed by the majority? So within the financing architecture, for those who have looked at it, we have the government financing, and this will not start after tomorrow or after Mashujaa Day, because the president already launched the community health promoters kitting program, which is part of the base. So the base is already covered by having community health promoter visiting households, and for the first time, we are looking at prevention as a resource mobilization tool. Our total expenditure have moved from around 250 billion to 550 billion annual. But our indicators are still bad. So if we continue encouraging diseases to continue getting to us, then our expenditure increases, and therefore we can never be sustainable. So that is where primary health care, that is where prevention gets its space within the financing discussions. The second thing that is important is that the bill on PHC is at the center of that piece. The second piece that is important is the fact that NHIF, which has been our social insurer, which again I have stated many times is a colonial outfit that has never taken shape in terms of changing to reflect the current structure of our economy. Now the current NHIF, if you look at it, it used to have admin cost as high as 24%. They have come down. So we are at around 11%. So 11% of the money that is being corrected is utilized to try and manage the fund. Best practice is below 5%, all 5%. How do we go there? So that we guarantee that those who actually pay, when they need care, it is paid. So that is a problem that these bills are trying to address. The other important thing is, how do we make sure that the informal sector participate and they get a benefit package, which you are entitled to, which you know, and you know what you are entitled at what level. Now, this is what these bills are bringing into space, so that the middle class, and I want to address much of whom are here, who for many years have been complaining, I contribute to a social scheme that does not pay for my benefits when I need them. Now, in this bill, the desire is that the Social Health Authority will pay a tariff. And when we talk about tariff, you know what you are entitled to. For instance, if it is an expectant mother who is due for delivery, what we are saying is that if I know delivery is covered up to 100,000, and I feel I am a little bit rich, I don't want to go to a public facility or a facility that is low. If I go to a higher level facility, that 100 of mine should be paid and not the bed. So therefore, I will not be saying I'm a middle class who contribute but does not claim, because where does my money go? if I don't get it paid. So that is a key thing that we are looking at. The last and important thing is that everybody here has a WhatsApp group. If you don't have, you are not from this country. Because every time you are added into WhatsApp groups on treatment, on needed, halabe, everywhere, digital halabes. Now, what we are saying is that it is possible for a country to pull together and generate what we call an emergency chronic illness and emergency fund. And the chronic one is kicking in when you have exhausted your social health insurance benefit. So instead of going to a WhatsApp, you are pushed up and that cost is absorbed. And that is an important component in helping our people access good care. The last thing I wanted to talk about on that agenda is the emergency care. We know that for a long time, we have been able to cover what we call ambulance evacuation. So when somebody has an accident and, for instance, they are taken into an ambulance, that ambulance is covered. But we have never covered where they are going. So that means when you come to the door of the facility, where the law says you must provide 24-hour stabilization, as a facility, I'm thinking it is private equity. If I take this guy, it will be bad debt. Actually, I am not doing well financially. So as a facility, you refuse or give reasons for not picking this person and stabilize them. Now, the emergency fund is addressing this issue by providing a fund where we as facilities or providers are able to bill for the 24 hours stabilization as also the emergency, which is ambulance evacuation. And therefore, Kenyans will not be going around nights, trying to get facilities to admit them. So in a nutshell, that is the whole spectrum. But just 1 minute, I said something else. I almost forgot that the FIF bill is an important bill. And why it is important is for those who remember that facilities used to have some autonomy to make decisions on how they use the money that comes to them. After devolution, we lost that component. And therefore, facilities don't have money. So what FIS is saying is that when the money is paid to a public facility by our social health authority, the public facility will retain that money and will be able to improve services the same way when a private and an FBO, a faith-based facility, usually retain the money that it receives to improve care to the people. We have seen it happen in Nakuru. Nakuru has been retaining 100% of the money paid. They are the only county in Kenya which really have been getting more money in public than in private. But all the other counties are the opposite. So I can say too much when you give me a mic to talk about healthcare financing and why I think we are at the right time. But I wanted to say that there was a plan that His Excellency the President committed to, and that plan has solutions and there is political goodwill. For the health sector, the stars are aligned. It is for us to take that opportunity to make sure that we get it right this time. Thank you.
So thank you so much, Dr. Mwai. 4 points that I've really taken home. Primary health care as a resource mobilization tool. Informal sector participation. Payment of services based on a tariff. And financial protection through the chronic disease and emergency fund. Thank you so much, my esteemed panelists, for this fruitful engagement. And I would just like us to stand in the front, take a photo, then we hand over to the MC.
Tuwapongeze kwa makofi tafadhali, ladies and gentlemen. Thank you so much, our panels. First panel haikupigwa picha, but ni sawa tu. Tuwapongeze kwa makofi tena one more time.
Thank you so much for that inspiring session. And now,
This is the day that the Lord has made. We will rejoice and be glad. Chief guest, the Ministry of Health is working very hard to ensure that we are aligning all these conversations that we are having today. And the health sector in this country has got to get affordable, available, and accessible, because we want to prevent, promote, and protect the people of this country. At this juncture, allow me to invite my boss and my cabinet secretary, Madam Susan Nakumicha. Tafadhali, a round of applause to my boss. This lady, chief guest, she wakes up talking about UHC. Before I sleep, I'll see a message about UHC. When I wake up, I see another message about UHC. She's kept us on our toes, and I am glad to say that we have been able to achieve the very best. Asante Waziri.
Our chief guest today, the head of public service, Mr. Honorable Felix Kosgei, my cabinet colleague, who has said that he's going to lift the standards of performance and making good of that you have been given, Honorable Moses Kuria, our senator from Uasin Gishu County, Senator Mandago, who is also the chair of the Health Committee in the Senate, Deputy Governor of Kericho County, my PSS, PS Modoni, you have done a very good job. PS Kimtai, equally doing a very good supportive job. Our PS for performance now, Veronica, PS for crops, CEO, COG, our partners, distinguished guests, ladies and gentlemen. Good morning. It's afternoon. Good afternoon. I know it's been a long time, head of public service. We've been here from Monday. But before Monday, we were in Nairobi, still discussing on universal health coverage. But today is one of the very, very important days. The day that we are talking about two issues. One is the human resource for health, and two, the financing bit. As head of public service, I know that anytime you hear that there's going to be industrial action, you start wondering how services are going to be provided. We have thought through this thing. All the sessions that have happened, I don't take notes. But this one on HRH, I have taken notes because we have a lot of challenges, but I've had solutions from the people who have talked here. And I know going into the discussions further, we are going to have solutions. Head of public service, we have over 200,025 health workers across all cadres, though 50% of that is for nurses and midwives. They're about 124,000, quite critical. Then we have medical doctors, clinical officers coming down across all cadres. So it is important, as a sector, we must solve this issue. What I'm sure of is that this time round, human resource for health, we are going to resolve it. That I'm sure about it. When we came into office, the Health Act of 2017 had given birth to Kenya Health Human Resource Advisory Council. And that council was meant to be a policy-making organ to advise on matters human resource between the national government and the county governments. Most of our HRH are at the county governments. They're employed by the county governments. But as a national government, we cannot close our eyes. Neither can we close our ears to their pleas. Because there is no patient or there is no Kenyan who is a patient of the county government and a patient of the national government. All patients are Kenyans. And therefore we have to work together to see how is it that we resolve these issues. And that's why today I'm happy, because I know teams have been working, and at the end of the day, we are going to have a solution. I was very deliberate to invite my colleague in charge of performance, because lazima pia tuambiane ukweli. You cannot be the doctor who comes and hangs your dust coat, and when patients are coming to queue, you are nowhere to be seen, and at the end of the day, you expect a reward. It doesn't happen. It will not happen as we move forward. We want everybody to meet their end of the bargain. You cannot be the kind of nurse where it was circulating on social media that you do not have a human face, yet you are taking care of a patient, and expect that us will look at you and applaud you for that. Everybody must pull their weight. I would like to invite my cabinet colleague, Honorable Moses Kuria, to come and speak to us, speak to the people here, and tell us what is it that you have, and tell us what do we expect in terms of measuring our performance. So let us please give him a round of a clap as he comes. Keep clapping until he arrives here. Keep clapping. You know, Moses likes encouragement. Please encourage him, encourage him, encourage him, encourage him, encourage him, encourage him until he's here. Moses and I, we call each other one government, because it must work. We are delivering as one. My brother, one government. Karibu.
Thank you. Thank you very much, my sister, Cabinet Secretary for Health. The guest of honor today, who is the head of public service, Mr. Felix Koskei, my sister, CS Susan Nakumicha, principal secretaries who are in that docket, my sister Mary Mudhoni, PS Haliki Mutai, my PS Veronica Duva, PS for crops, and I think PS for interior is also here, but he has not been mentioned so that we don't scare you. Ladies and gentlemen, good afternoon. I'm very privileged and very pleased to be here to witness this very important dialogue and conversation around our health issue. And one of the things that make me very happy, I was just whispering to Senator Mandago here, is that for the first time in a long time, this country is now focusing on issues. We have so much conversation, we have so much of discourse on issues that affect this country. In the previous years, this kind of conversation was unimaginable. But now that we are here for a whole week talking about health, it is something that is really, really, truly very encouraging. When I look at health issues, I want to compare it with a car. Let us assume our bodies are motor vehicles. So to talk about a car, if the car is broken, we need three things. We need tools and commodities to be able to fix that car. And of course, we need money to fix the car. But more important is that we need a mechanic. And a mechanic, without him or her, the tools, the money is irrelevant. That is why I want to applaud this coming together of you people whom we depend on. You know, gari yako ikikwama, sometimes we can try and fix it. When your house is leaking, you can try and do it yourself. But none of us can be able to treat ourselves. And I saw it during COVID, when as a COVID survivor, I was sharing the ward with very highly qualified doctors. And I asked one of them, Daktari, kwani daktari anagojeka? And it was actually humbling that even a doctor would require another doctor to treat him. So you are all very great people, and you are very important people and very special people without whom we can't work together. Let me start first by applauding the great work which my sister and the team are doing in this space of healthcare. Actually, let me say, because I've been around for some time, the amount of work that has been done within our health space for the last 11 months is equivalent to some 20, 30 years of work there before. I know that could not have been possible without cooperation from all the players. As cabinet, every other day we have something that we are discussing about healthcare. And in this regard, I also want to thank especially the unions. You know, I asked Susan yesterday when she insisted that I must come here. Are you sure it is not going to be a fight with the unions? And I'm delighted when I saw my friend Washira here, very calm. You know, before I came, I was doing some pleasure. I only came because I was told Panyako is away, but let me say that it is really, truly inspiring. Some jobs you can't do for the sake of a job. Some jobs are beyond a job. Some jobs is a calling. And the kind of work that you people in this space do is truly beyond a job. So let me first encourage our unions to really stay on that trajectory of engagement, of constructive, positive engagement, because they are your patients, they are your mothers, they are your fathers, they are your husbands, your wives, your children. We don't have people belonging to unions and others belonging to government. We are in this together, and we should stick together. And I know, as a cabinet secretary in charge of public service, that there are some outstanding issues there, issues to do with especially the collective bargaining agreement. And I know that that's a conversation we have to continue to have. But that conversation and that engagement must continue to be driven by the values that we have got a shared destiny and a shared responsibility. We cannot achieve it as government alone. You cannot achieve it alone. So Susan and the unions, please stay on that trajectory. And now, as your minister, I want to offer myself, because I think I've got some few skills there in trying to achieve some consensus. I'm a certified dowry negotiator. And I can be able to assist you with some of the experiences to ensure that our CBA remains on course, and to ensure that, that ultimately we do what is good for everybody. But essentially, we do what is good for the people of this country first, given our current situation, given where we are, and I'm very pleased that I'm actually preaching to the choir, because I'm advised that the unions are already in that trajectory. When on that, let me say that, and I've talked to the CEO of the Council of Governors, Mary Muti, who is here, and Susan, in the next 2 weeks, I would really want us to have, you know, a conversation with all the governors together with my ministry and your ministry to really look at this issue of harmonization. Because I know it's a sticking issue. Yesterday, I got an SMS message from some health worker, I think it's a nurse, in my county of Kiambu. And, you know, it was really heart-rending when she told me that she is we have got 3 people doing the same job in that facility. One is a casual, the other one is a contract worker, the other one is a permanent and pensionable, and they are being paid differently. And I want to agree with Wazishira. That is a question of social justice and social equity. It's a question of a human right there. When you have people who are doing the same job but are being remunerated or treated differently. I'm aware that in the previous government, when we tried to implement the universal health care, and we left some orphans, some 8,000 or so orphans who are trained on UHC. And now, as a senator, that is something I would really want you to discuss within the Senate, and I want to ask Council of Governors to also take it up. It does not make sense for us to go out there and recruit somebody when there is somebody who has been trained, we have invested in that person, we use money, not our money from our pockets, but money belonging to the taxpayers of this country to train those people. So please, the sensible thing is, before we hire other people, can we ensure that these people whom the country invested in, we are able to deploy them, work with them, and then create space for us to be able to train other people. There's something also that I want to add here from the point of view of performance. The whole issue, now we are very focused as a government on the issue of performance and delivery. And all of us have signed a performance contract. But our people in the counties are outside of that performance contracting regime. Unless you tell me they are going to be paid by money coming from elsewhere. But if they are going to be paid by these taxpayers, it is about time that you people, the people of Kenya, demands that everybody, whether you are in national government, whether you are in county government, you must sign a contract with the people of Kenya through performance contract. Within government, they have got their own TORs, their own deliverables. Someone is a driver, someone is a mechanic, someone is a cleaner, and they have a contract, and they are being measured. Yet we have got a highly qualified doctor, a physician, in a county hospital who is not on performance contract. That is not right, and it's not fair. So we were going to work together to ensure that even senior people, senior doctors within brought into this particular regime. Susan, let me also congratulate you for the, that you've brought, focusing on the other elements, and especially giving some sense, one, to this whole architecture of having the primary health care under the Afya Nyumbani architecture. That for the first time now, we can have a level 4 hospital sponsoring a level 3 facility or sponsoring a level 2 facility. 90% of the problems of healthcare that we face can be finished at that local level, at the level 2 level and level 3 level. But we need to invest more to transition our people's mindset. There's a time where I come from, unless you go to Kenyatta National Hospital, you've not seen a doctor. And times have moved. So we need to work together to actually sensitize our people to agree and to appreciate that it does not matter where the health facility is, as long as you get the service. And that is why I'm very much excited about your facilities bill that you put in Parliament, the social health financing, and also the digital health that has now been passed by Parliament. Finally, let me talk about this issue of financing. The biggest problem we had in the other government is that we tried to blanket everybody together, even rich people. We were doing a pilot in a county called Nyeri, and we were telling someone, a rich farmer in Odhaya, please put back your tip bonus money to your pocket. Government will pay for you. That person did not say us to pay for him. That person did not tell us that they have a problem paying. But the way your team has structured the social health insurance is really remarkable. And I'm sure we are going to start seeing the benefit, within the next 1 year. And somebody here has spoken about mobilizing farmers, mobilizing cooperatives. You and I were working on an initiative which we are going to continue for our border sector, a sector also which is unfair. When you talk about the issue of adverse selection, it is affecting a sector like border more than any other sector. These young men, mostly men, when they have accidents, they go to hospitals. They cannot be covered by NHI for the plate, ile chuma ambao wanawekwa. And really, I am only for that. I'm very passionate about the social health insurance so that we can eliminate this issue of adverse selection. Good people, it is a privilege to serve. It is a privilege to be in public service. And as I've said before, most of us are not in public service. We are in public employment. We're just employed by the public. And we need to have a conversation with ourselves. How can we transition from being in public employment to being in public service? It starts with this kind of conversation, working together, and knowing that we have got many more reasons to work than a salary. For me personally, the primary reason I work hard is what I go to heaven. So give yourself a reason for why you need to work hard. It can't just be a salary. It cannot just be to please your boss. Some of these things that are calling to public service requires a higher calling. And finally, Susan, I have a problem I want you to assist me with. The issues of disability in this country are very serious. We have to work together to make life bearable for people who are living with disability. But there's a special phenomenon. An head of public service is here. I'm working on a report. There are some things which are uniquely Kenyan. Within my first 1 week as a minister in charge of public service, I've discovered that Kenyans are getting disability, most of them at the age of 57. Mtu akijua retirement age inakuja karibu, all of a sudden wanakuwa na disability, wanakibia pale, wanapewa ka certificate. Now who am I to say whether they are actually disabled or not? I can only depend on you guys as professionals. But me, I think there's kuna ukola hapo ndani yake. And I want to tell the public servants, please, wacheni hiyo mchezo. Miaka yako ya kuritaya, enda nyumbani. And I'm now here to assist you to make that transition smooth. But this thing of someone, amebakisha mwaka moja, miaka mbili, anakibia pale kwa Council for Disability, anasema unajua hii jicho jana, haikuona mamangu vizuri, kwa hivyo, nipatie hiyo certificate. No, hiyo ni ukora, and we must live true to the spirit and the values of the public service. So with those few remarks, let me take this opportunity to invite the guest of honor, the head of public service, Mr. Felix Oske, to address us. Thank you.
Let us have our seats. It is always very, very difficult to speak after Kuria because he mixes politics with serious business. The Cabinet Secretary, Minister of Health, my sister, Honorable Susan Wafula, the Cabinet Secretary in charge of Public Service, Performance and Delivery Management, Principal Secretary is present, led by Mary Mudhoni, Kimtai, and Dr. Rono, and Madam Veronica Nduva, the Deputy Governor of Kericho County, the Chairman of the Health Committee of the Senate, Mheshimiwa Madago, members of Parliament that are present, development partners present, senior government officials present, members of the county assemblies present, and most importantly, the health care workers here today. Ladies and gentlemen, good afternoon. I'm most pleased to join you all for the first of its kind National Human Resources for Health Dialogue. Today's session is the culmination of consultations that began at the Windsor Cove and County Club from 5th to 7th October 2023 on the subject of the coordination of the regulation of all health cadres, as well as those held on 11th to 12th October 2023 at the same venue. Those very inclusive and enlightening discussions will inform part of our dialogue today. Ladies and gentlemen, therefore, I extend a special acknowledgement to the diverse assembly of healthcare professionals in attendance today. Their participation and invaluable contributions are indispensable to this discourse. To all the health workers and all stakeholders, I salute you for standing to be counted at this historic ground of Kapkatet ground in Kericho County. We stand at a moment of exceptional possibility. This is a moment when the dream of universal health coverage that has been elusive from the dawn of the Republic is now attainable and within our reach. This is a moment also when the lessons learned from the COVID-19 pandemic and the unprecedented magnitude of the devastation it left in its wake are inspiring a new approach to our nation's healthcare. We must seize the moment. Since health is a shared function between the two levels of government, the two tiers of government are therefore jointly summoned to formulate strategies that guarantee the provision of secure, effective, and high-quality healthcare services. Ladies and gentlemen, I want to say to all the doctors, clinical officers, nurses, and all other health workers across our nation, as I speak to their representative with us today, you are seen, heard, valued, appreciated, and respected. Every day you go out in your workplaces, driven by a passion to heal, a desire to make lives better, and your hearts and mind solely focused on making Kenya a healthy nation, one patient at a time. And for that, on behalf of the eternally grateful nation, we say, Asanteni sana na sana. Our thanks as a nation must extend beyond mere words. Our gratitude must be manifested in us, building a robust healthcare system that is characterized by a well-trained and well-motivated human resource, well-equipped facilities, well-stocked pharmacies, and well-thought-out policies and strategies fit for the challenges of the 21st century healthcare. We must do this because health is the well from which we water our national prosperity, happiness, and our dreams of a better Kenya for all. Today, we shall take cognizance of the multifaceted challenges faced by healthcare workers at both the national and the county levels. These challenges encompass, firstly, the question of staff mobility, what has come to be known as labor migration. Chiefly, the fact that once you are employed by one county government, you can only move to the next county if you resign. The second challenge is training, retooling, and personal development. The third is staff welfare and career advancement. The fourth is performance management and motivation. And the fifth is healthcare worker safety and well-being. It is incumbent upon us to collectively identify the most pragmatic solutions to address these and other challenges. And what better avenue to achieve this than through sustained dialogue? I am persuaded that this historic apartheid ground will make history yet again as the place where lasting solutions to the human resources challenges facing health in Kenya fight and the commitment to their resolutions began. The landscape of Kenya's healthcare sector is not wanting for policies and institutions to guide and support the human resources for health. However, our government has swiftly recognized the inherent risks posed by the absence of a central coordinating mechanism to harmonize policies and strategies that pertain to various facets of human resources for health. We have recognized the futility of conceiving additional policies in the absence of an institutional framework that evaluates existing policies and offers guidance on the most prudent course of action, which may often involve enhancing the operationalization of the existing policies and fostering coordination among existing solutions. Distinguished delegates, this realization prompted the national and the county governments to establish the Kenya Health Human Resource Advisory Council. While instituted under the Health Act of 2017, the governing council of this council had then not been constituted. During the promulgation of the Act, a situation that created a void in the coordination of the human resources, health resources related matters. Our swift constitution of KHRAC, conducted in close consultation with the Council of Governors, exemplifies the government's unwavering commitment to offering sustainable solutions to the long-standing challenges affecting the health sector. I extend my profound appreciation to the leadership of the Council of Governors for their prompt and wholehearted commitment to working alongside us in the operationalization of the Council. We are confident that the Council will play a pivotal role in refining the training, development, and management of our healthcare workforce. Ladies and gentlemen, today we are privileged to listen to the voices of our healthcare professionals, those responsible for their training and oversight, and those tasked with providing policy direction regarding human resources. I want to thank my assistant, the Cabinet Secretary for Health, who has painstakingly endeavored to ensure that the dialogue in this area shines a spotlight on the experiences of healthcare workers, and that we, the custodians of public service, listen to their voices in vibrant dialogue. Congratulations, my sister. You've worked very hard. So the ultimate objective of this dialogue, and especially today's outputs, is to formulate specific action points and realistic timelines for the implementation of critical initiatives aimed at enhancing the status of our healthcare workforce. The government of Kenya, under the leadership of His Excellency the President, remains steadfast in its commitment to fortifying human resources for health. We also recognize that this endeavor in isolation is insufficient. We are concurrently engaged in fortifying other pillars of our health system, such as health products and technologies. This is the reason why His Excellency the President launched the local manufacturing expo last week on Friday, and also the reason why Cabinet directed KEMSA to give locally manufactured pharmaceutical products preference over imports. These and other actions are in keeping with the administration's plans to bolster local manufacturing, promote the digital health ecosystem, and increase healthcare financing. These facets must align harmoniously to facilitate effective delivery of the much-awaited universal health coverage. We currently have 4 pivotal draft bills, meticulously tailored to expedite the achievement of universal health coverage. These include the Social Health Insurance Bill, the Primary Health Bill 2023, the Facility Improvement Financing Bill, and the Digital Health Bill 2023. We extend our gratitude to the honorable members of the Parliament in both the Senate and the National Assembly for their steadfast commitment to expediting the deliberation and passing these essential bills. Ladies and gentlemen, having excellent health policies will count for nothing if they are not carried out well. It is critical that we collect good data on our healthcare workers to see if our plans are working. I have been informed that in the region, Kenya leads in effectively implementing the WHO-supported National Health Workforce Accounts, a measure that enhances the accuracy and the utilization of health workforce data, and which helps us measure the impact of efforts to improve human resource management. Going forward, we will have a clearer understanding of essential health workforce data, including employment, retention, and attrition levels. Both levels of government are faced and continue to face challenges in health worker staffing and deployment. The answer is to deploy a bottom-up approach of listening to everyone in the health ecosystem. From the voices that we have heard thus far, we must adopt the workload indicators of staffing needs approach, which allows us to base healthcare facility staffing on actual workloads and stress assessment, a move focused on prioritizing the well-being of our healthcare workers. As I conclude, I want to echo and congratulate the Minister of Health for being in the forefront in trying to fast-track the primary healthcare strategy. It is the only way we can even cut down on the expenses in our healthcare environment, because prevention is always said better than cure. And all over the world, all of us have gone across the world. You realize that curative stage, you realize there are very few people, and even the expenses are not as much as the money that has been allocated to primary health care. Many years ago, when we were in secondary schools, we were taught about prevention. We were moving from one household to another one, constructing toilets ourselves, from one home to another one, constructing toilets, going from one home to another one, trying to teach them the little knowledge that we were taught in our primary schools on how important it is even to wash your hands from that toilet, and even to wash again when you are setting yourself to eat your food. We were even told, even to be careful. Greeting is okay, good, it's African, but be very careful, because sometimes you can greet some people that can infect you with very dangerous diseases. And we were very careful also. Whenever we see somebody who is not bathing very well, who is not clean enough, you just wave and run away, because you knew for sure you'll end up forcing your family, your father, your mother to sell a goat or a cow to take you to hospital. So the best thing is avoid greeting him, face the community's blame that kijana ya mzee fulani ameringa siku hizi kwa sababu ameenda secondary, lakini umejikinga na ugonjwa. And of course, we are in a good space. We are in a space where Moses Kuria said, our minds are meeting. From the unionist, from professionals, from the government, all of us, from the development partners, all of us are speaking the same thing. And that thing is a conversation on issues. Issues that are geared to bringing solutions on the table. And as government, we are happy about the space. This space that we have established in this country by this administration will see us going far, not only in health sector, even across the sectors in the country, because each and every citizen of this country now is feeling and enjoying public participation as is provided for in the Constitution. We are happy about that, and we are going to take whatever you tell us, whatever conversation, whatever information you submit before us here very seriously. And that is why your cabinet secretary in this sector has been busy taking notes, because she wants to go and structure her strategy in line with the needs or the requirements of the people. And we are very happy that all of us are candid, and we are very, very well advised. Ladies and gentlemen, we have come a long way. You see, as a professional, and if you can remember, I know there are people who are elderly here who have been in healthcare sector. You remember those days when a nurse was in a uniform. She used not to pay matatu fare. She used not to queue. She used even not to queue even in supermarkets, because everybody respected and they knew that this nurse perhaps is in a hurry to go and save a life. They were always there was a giving way. You give way. To give way when you see a doctor, when you see a nurse. But what has happened now? And that is what we need to discuss. Why is it that this critical and very, very, I can say, a very obligatory situation and a sector that we know it makes a whole difference between life and death are not treated the way they were before? Why are we the same? Why is it that nowadays an ambulance is blocked by people? They don't care. I want you people to ask yourself. And you can see, simply put, it is because even those who are in that profession have not kept the profession high. They have lowered their guard, and they have become ordinary like anybody else. You get them in all manner of cases, arguments, fighting in the bars, being arrested because of theft. So nobody, as we speak, cares whether you are a doctor, whether you are a nurse, whether you are a health professional. They don't care when you are queuing on the same panga line, because they know you may be hurrying to go and kill somebody. No treating. And all things, ladies and gentlemen, is the decay of our value system. We need to ask ourselves, how do we turn around? As much as the government is creating an enabling environment, as much as all of us are agreeing that we need to take a particular trajectory, can we see our morals? Can we see our social space? How are we going to return back the profession that we knew and that we know back to where it was? It is a question to you people. Go and think about it. No matter how much we pay a salary, no matter equipment and facilities and commodities are provided, if we don't live true to the profession that we have been called into, because medical world, medical field is not about employment. It is a calling because you do extra. No one can compensate you in what you are doing. Can we uphold the tenets? Where is our code of conduct? Can we go back there? And that takes me to the next. health sector has become almost #1 corruption environment. Where is it coming from? And yet, all of us in the space are professionals. Where is it coming from? What is it? Is it the space in time where is it the 21st century? What is this that has allowed the entire structure of the citizens to be infiltrated by corruption? What should we do? And it starts from even admission of students. Those who are admitted to medical schools, they have stolen their exams. They cannot cope with rigorous training in medical schools, and therefore they bribe also the lecturers so that they can be given marks. This doctor, who has crooked himself from primary, secondary, in university, has known, and that is his field. He knows there is nothing that pinches him about corruption. He will continue perpetuating corruption even in his workplace. What do we do? And I want all of us to think, how are we going to eliminate corruption in our sector, in our field, in our profession? Let us stop corruption. Let us not be selling drugs. Let us not even be segregating and, discriminating. People have lined up, you are coming to call number 5, and yet number 1 has sat for 1 hour. This is corruption. Why do you misuse government facilities? Why do you steal time? All these things, if we address them, ladies and gentlemen, will make us really come back to where we were, and we shall be respected as people. So I urge all of us to seize this moment, contribute all what you think needs to be done for the sector to improve, and at the same time, let us also reflect on what might have gone wrong so that we change course and focus on the right thing. We are all here together. If I get sick now, I'll be rushed to Kapkatet Hospital. It doesn't matter whether I'm a head of public service, or I'm a Moth, or I'm Nakumicha, or I'm Kuria. First of all, you rush there. Therefore, I want to urge all of us to reflect and come together as one and transform the sector. Secondly, as we are asking for that, we are also cognizant of the fact that even remuneration is not enough in the sector. You put a lot of time, you even have a lot of risks. Even the allowances that I saw the other time that you are given and practicing allowances, some few allowances are for 1970s. Can we transform this place so that we can remunerate all of us in a manner that we are all going to be happy and we are all going to be motivated to dedicate our lives and our time towards helping our common citizens? So as I conclude, I want to say that this is the time that we are starting Afya Nyumbani. Afya Nyumbani should be now the flagship of this administration. We have to speak, we have to act, we have to sing Afya Nyumbani, because that is what this administration wants to invest in. And I know we are going to succeed. So as I conclude, I once again extend my heartfelt gratitude to the dedicated officers of the Ministry of Health and the Council of Governors who have labored tirelessly to bring this endeavor to life. We trust that this initiative shall play an integral role in the quest for sustainable solutions to the enduring challenges facing our health workforce. I promise you all my unwavering commitment and support in addressing these challenges, and I assure you of the support of the entire administration for this endeavor. Our challenge is to bend the arc of history to ensure that everyone in Kenya has access to the affordable, high quality, and easily accessible health services. This is the moment for us to rise to the occasion, to meet the challenges head on, and to give the current and future generations a better healthcare system. Asanteni sana, Mungu awabariki.
Tumpongeze tena our chief guest kwa makofi tafadhali. We can do better than that. Let's put our hands together to our chief guest. Thank you so much. And I'd like kindly request you, we can be seated kindly. I'd like to request you, our chief guest, kindly if you can step back to the stage again.
Thank you so much, our chief guest. Before I hand over the mic to the MC, I would like to recognize the presence of the CEO, Council of Governors, Madam Mary Mweti. Please wave to the crowd. We are very happy with the Council of Governors. We have been having a very good collaboration, and especially throughout running through the bills. Asante sana. I also would like to recognize the presence of the CEO Public Service, Dr. Simon Rotich. Asante sana. And not forgetting our host, the Deputy Governor of Kericho County. Thank you so much. We are happy. We have been feeding on the tea every now and then, and it is sweet. Chief guest, I would equally wish to acknowledge the partners who have made this happen. We have the US aid. We have, I don't know if they're in the crowd. Thank you. We have UNFPA. We have WHO. I can see Dr. Diallo. We have UNAIDS. If you're there, just wave to the crowd, please. And I'm sure in absentia, we have Global Fund, World Bank, PATH, UK FCD, and many, many, many others. Sorry for the small commotion, but we will be fine. At this juncture, I want to take back the mic to the MC, our able MC for the 3 days who's been with us. Karibu.
Asante. Tumpongeze PS wetu na makofi tafadhali. Thank you so much. Our chief guest, we would kindly request you witness the Kericho Health Workforce Declaration. So I'll kindly request you to step back on the stage kindly. And I call Professor Frank to help guide on this part of the program as we witness the Health Workforce Declaration ya watu wa Kericho. Jameni, wale tuko mvua ni mzuri, tuwapigieni wageni wetu waheshimiwa makofi. Thank you so much for this wonderful day. Karibu sana Professor, you take us through.
Asante sana MC. We are coming towards the end, but we do have something very special that we want to do. Hopes, we are very grateful to have you here. Thank you for taking your time. And the message has been very consistent, that we are standing on the cusp of history. We are looking at tripartite relationships that are now focusing on issues. That is something that has been mentioned all around. Now, when the Kenya Health Human Resource Advisory Council was established, 3 things were told to us. First, by the president himself, and he says you have to be very non-partisan, and you need to know that you are there to serve the counties, the national government, the healthcare workers, and the communities. Number 2, my CS told us that our deliverable is a happy healthcare worker. So if we are existing and healthcare workers are miserable, we are working ourselves out of employment. And number three, before I get into this, the message was communicated that don't just be a toothless dog. KHRAC, the Kenya Health Human Resource Advisory Council, is an intergovernmental state corporation in the making. 3 of my board members are from COG, and 3 members are from the Ministry of Health. So it's actually a proper marriage. So as I stand here, I represent those interests. Allow me to take 2 minutes to quickly read through the declaration. And this is really, really important because a lot of unions have put in time into this. So PSs, just indulge me, just 2 minutes. So as a preamble, very, very briefly, we, the conveners of the National Dialogue on Human Resource for Health, Ministry of Health, Council of Governors, KHRAC, had the first series of dialogues on 11th and 12th of October in Nairobi, and another dialogue today. And it's through that, and citing a lot of policy, legislation, and statutory provisions for human resource for health, that we all agreed to work together towards 17 clear goals as part of our declaration. Now, you'll forgive me, I will not read each and every word of the 17. I will just say what each of the 17 means in the interest of time. The first thing that the unions, the Ministry of Health, and everybody agreed to do was to proactively work on the primary care networks so that we include other cadres that are not very well, don't feel very represented. I need to emphasize that it's not that they are not represented. The messaging was lost, and they actually did not see how they fit into the primary care network, but they are represented. The second one is to move towards introducing county-based training programs so that we don't have to take healthcare workers to Nairobi or Eldoret and deny counties personnel. Number 3, postgraduate training responsibility. The pledge, and this was a request from the counties, is the national government needs to play a more active role in supporting the salaries during that period. Number 4, health specialists. We need to have a framework that allows counties to share health specialists. Number 5, we need to standardize internships because there are cadres where we have a problem with internships. Number 6, we need to improve the mismatch between supply and demand of health workers, and that should inform training so that we don't produce people we don't need. Number 7, we need a dashboard for all health-related information. Number 8, we need a framework that allows us staff to transfer from one county to another. That is a very big motivating factor. A husband joining the wife. That framework needs to be placed. Number 9, and this is a very big pledge by the ministry, to provide a mechanism where every intern who completes internship has an opportunity for a fixed period employment so that they gain some experience before they are released into the labor market. Number 10, adapting and mainstreaming the contract staff, including the UHC staff who are very, very disgruntled. I need to say that everything here has a timeline, and most of them are 3 months, 6 months, or 12 months. Number 11, provide comprehensive medical insurance for all public sector healthcare workers within 3 months. Number 12, facilitate the implementation of pending promotions and redesignations as a way of recognizing the work done by health workers. Number 13, support development, review, and alignment of schemes of service. That's a big problem. It has a timeline of 12 months. Number 14, engage Treasury and other actors to figure out how to bring in more money into the health sector. Number 15, establishing a centralized mechanism for collective bargaining agreements with all employers. Unions are having a lot of frustrations when they have to negotiate with 47 counties. Number 16, and this is a pledge by the unions, and it was not easy, commitment by all health worker unions towards industrial harmony and peaceful relations for the period of the declaration, based on pledges contained in this declaration. And last but not least, and hopes I'd beg your indulgence on this, facilitate operationalization of KHRAC as an independent and fully functional self-corporation with the responsibility of delivering this. This has come after weeks of a lot of deliberations, and we are calling it the Kericho Declaration on Human Resources for Health in Kenya. So what I'm going to do as the last part of the program is I'm going to kindly invite a number of guests, and I think I'll need a bit of support now, starting with our Head of Public Service, Mr. Felix Koskei. If you could just join us here. My CS, Madam Susan, CS Moses Kuria. Please sit down. Okay. Yes. CEO Mwiti, COG, join us, please.
There's a point which I think.
Our union leaders who are here, you know yourselves. Dr. Miskela.
This last point, you know you're doing on behalf of the ministry.
Yeah.
It's not a KHRAC thing. So this one will be edited.
I'll explain why we put it like that. Yes, okay. Yeah, sure. Yeah, they're here, Charles. Yes. Peterson, I think I did see Peterson somewhere. Mr. Peterson Washira. Ashira and Nyakundi. Thank you very much.
Also, Kericho County Deputy Governor, Engineer Fred Kirui, kindly
All right.
step to the podium.
So thank you very much. So here's what we are going to do. So we have the declaration in front of you, and we also have a board here. Our humble request is we are going to need you to sign twice. One for ceremonial purposes on the board, and then the declaration that's on the table. So I'm going to ask Hopes, our CSs, to kindly sit. No, Hopes is not signing. Hopes is... Okay. Peter, Gibore. Gibore, please go and sign. Yes, anasema sign tu haraka haraka. Please sit down when you're signing. Next, we have we have Ashira.
They could all sit down.
Yeah. Please sit down if you're signing. Dr. Miskela and Charles, please sit down. As you finish signing, please also sign on the board because of the photo. As you finish signing, please sign on the board because of the photo.
Tuwapigieni makofi basi wanapo sign Kericho Declaration. We can do better than that. Tuwapigieni makofi tafadhali.
And then immediately after this, it is our photo session. We will start with the CS handing over, of course, the document to Hobbs. All right, still signing?
Still signing, please, our CSs. And as we are doing this, I know our KHRAC board members are somewhere. Do you mind joining me on the stage just for the photo session? KHRAC board members.
All right, like I announced earlier, the first photo session that we'll have immediately after this is Health CS handing over the document to Head of Public Service, that is Honorable Felix Kosgei, in a short while. And then from there, we will have the second one, all the PSS, all the CSS. And then, of course, we will have Uasin Gishu County Senator as well join the photo session. And then a representative from the COG. COG.
Oh, thank you very much. Yes.
All right, so the first picture that we're having is CS handing over the document to Head of Public Service. We'll have the first picture, CS, of course, handing over the document to Head of Public Service, Honorable Felix Kosgei. Tuwapigie makofi tafadhali. Let's appreciate them one more time. Tuwapigie makofi. Very nice, all right, very nice. And then, of course, they have to sign this. They have to come to sign over this. There's another signature over here. So tukimaliza hizo picha, tutakuja upande huu, and then we sign as well. The second picture, we have Head of Public Service. We have both cabinet secretaries, all the PSS that are here. Uasin Gishu County Senator Jackson Mandago, and the COG. That is the second picture that we will take today, all right? I will repeat again, Head of Public Service, both our CSS, all the PSS that are around, Uasin Gishu County Senator Jackson Mandago, and COG as well. Karibu sana. And then also we have just coming in is the Kakamega County Governor Honorable Fernandez Baraza. Tumpigie makofi tafadhali. And then initially the third picture that we are going to, you remember that during the panel we had the HRH committee. Wako wapi? HRH committee, where are they? HRH committee, kindly. All right, so if you've taken a photo, in the second group, we will just step aside, and then we leave, of course, Head of Public Service and the CSS.
Asante sana. Tafadhali naomba kama umepiga picha from the first photo and the second, kindly you take your space.
Kama umepiga picha, tunaomba kindly you step back so that we can have more groups coming in. Union officials as well. Wapi union officials? We have the union's officials taking the photo, immediately followed by the HRH committee, all right? HRH committee. If you've taken a picture, kindly step back kidogo so that we can do this in a swift manner.
Asante. Kindly, I'm requesting we remain with all our CSs so that they can finally sign this board. Tuwapigieni makofi tafadhali, ladies and gentlemen. As
Let's appreciate them tafadhali, tuwapigie makofi. There's a felt pen over there.
Asante sana. Kindly.
And then also the board for KHRAC to be on standby. The board for KHRAC to be on standby. They prepared all this, and in a short while from now, they're going to take a picture.
Thank you. I think the pictures are done. Waziri, before we give Governor a chance to talk to us, we have a very important board here that we must also sign kindly. Kindly give way. Kindly, if I'm requesting everybody to take a seat kindly.
Tuwapatie nafasi so that the pictures can be captured as they take the signing at the board. First to go is Health Cabinet Secretary, Honorable Susan Nakumicha. Mpigieni makofi tafadhali. Let's appreciate Waziri, followed closely, of course, by Cabinet Secretary, Honorable Moses Kuria. Tumpigie makofi pia naye. Very nice, all right?
Tuko na Chairperson Kenya Health.
Mary Mwiti signs on behalf of COG. All right, chair is here. Let's appreciate the chair. Pigeni makofi, Kakamega Governor Honorable Fernandez Baraza. Pigeni makofi tafadhali.
Professor Frank anaweka signature yake pale.
Anaangalia mali. Tupigie makofi Frank tafadhali. Pigeni makofi. Very nice.
PS Labor.
Okay.
The photographers, thank you so much. I think, ladies and gentlemen, tuwapigeni makofi, our leaders makofi.
So let's remain with the CSs, PSs.
The photographers are requesting we take one picture with the CSs and the governor strictly. So kindly, if you're not a CS or a governor, I'm kindly requesting. And PSs, sorry. I'm requesting my colleagues to kindly exit the stage. Waziri, kwa heshima, one more picture kindly. Kindly, Waziri. Our head of public service, kindly. This one important picture we are requesting with all the CSS and governor. Council of Governors, kindly. Asante. So, camera guys, kindly, let's get our shot so that we don't keep our CSS. There you go. Hii ni picha ya gazeti. Asante sana. I think
all right, the board is here, KH Ruck. And then after that, we remain with the head of public service, the CSS, and the PSS only, kindly. Eh?
Wakenya tunapenda picha, kwa hivyo mtatuiwia radhi. Ukipiga picha, una post. Asante sana. Tuwapongezeni tafadhali kwa makofi.
Let's appreciate them. Tuwapigie makofi tafadhali.
As guided by our Cabinet Secretary Health, ladies and gentlemen, I think we are going to give our beloved governor.
Well, good afternoon to you. A great moment right here in Kericho County, that is the Capital Stadium, where we are witnessing the signing of the Kericho Declaration of Human Resource aspects on health. Just, that push by the different stakeholders on the health sector or in the health sector are trying to ensure that they come up with ways and modes that should be followed as a country, first of all, to attain universal health coverage, but of importance to make sure that then that aspect of human resources is addressed. I will allow us to go back to the speeches, and then later on I'll come back, give you a recap of this. My name is Linda Alela. Let's cross over and listen in to Kakamega Governor, that is Fernandez Baraza.
Good afternoon. First and foremost, I want to apologize for coming late. I know Waziri wa Afya made sure that my program that was supposed to commence at 2:30 has been pushed forward. However, I'm here and I'm very happy to join this team to support our healthcare. Matters healthcare, we know is a devolved function, but as the chair of Finance, Planning and Economic Affairs Committee of the Council of Governors, I want to join my colleagues in embracing the collaboration that we have with the national government. We believe that you cannot deliver alone without working together with the national government. So I want to take this opportunity to embrace the discussion that has been here today and just to commit that as Council of Governors, our priority is to make sure that we advance the universal health care to our people, and we also want to appreciate the support that we've gotten from the national government, especially on our primary health care. Our CHPs are very excited, and I know on Friday, when His Excellency the President, Dr. William Samoei Ruto, will be launching the kits, that will be the climax of equipping our CHPs. Others been our shukuru sana, and I wish you fruitful discussion. Asanteni.
Tumpongeze tena His Excellency kwa makofi tafadhali. Thank you so much. I think we've come to the end of our today's program. Ladies and gentlemen, I request that we be upstanding for the national anthem. Then immediately after the national anthem, we'll allow our waziri and our chief guests to leave at their own pleasure. Thank you so much. Before the national anthem, ladies and gentlemen, I'm guided to reintroduce back the head of public service to officially close this expo. Karibu sa. Then immediately we do the national anthem.
They are sitting down or they are standing? Mukae chini sasa. The cabinet secretary is present. Susan Nahumisha, Moses Kuria, CSS, PSS present, Mary, Kimtai, Veronica, and Paul. Distinguished guests, ladies and gentlemen, good afternoon. I wish to now take this opportunity, as I have been directed to do, to first of all thank the CS Health for a well-planned meeting, a huge convergence of the entire country. I want to also thank all of you for coming, your enthusiasm, your real candid suggestions, discussions, your freeing of your mind so that we can read it. And of course, you are setting aside your busy schedule so that you come for this function. I want to thank all of us. From government, I want to assure you that we are serious. And we are dead serious. This sector has to transform. It has to change. This sector has to be citizen-centric. The citizen has to be the center. It is not the ministry, it is not the president, it is a citizen of this republic that will be going around it, coming with policies, bringing in all what it takes, including investment to ensure that the health of the citizen is ensured. And that is why I say we are dead serious. Secondly, the 4 bills that we want to thank Parliament. We want to thank all those who participated during public participation. We want to thank the development partners who really came in handy in terms of support, in terms of technical assistance, that made these 4 bills pass through all the stages that tomorrow will be the culmination of seeing UHC launch as a reality, because we are signing tomorrow the 4 bills in Nairobi. Finally, as I told you, kutoka sasa kwenda mbele ni afya nyumbani. We have to ensure that afya nyumbani will stick and stay in your lips wherever you go, whatever you do, whatever service you are offering, ni afya nyumbani. For those few remarks, let me now take this single opportunity to declare this function officially closed. Thank you very much.
Asante sana. Tumpigie makofi mpaka afike mahali pake pa kuketi. Thank you so much, our chief guest. Thank you so much, everyone, for making this happen. Kindly, national anthem. Asanteni sana. God bless you. DJ, tupe muziki tafadhali.
All right. Well, Joash Nsari, we would say that this is the climax of this Mashujaa conference, that is Universal Health Coverage Mashujaa Conference, a day that has been, activated by lots of activities beginning morning, perhaps one of the days that we have begun this event very early, and looking at the numerous guests, that is at the level of government, that have, joined in on this celebration and this historic moment that is on universal health coverage, and thus attaining that freedom as to the question of health. I think it's the day that perhaps we would say is the climax of all the days, and I know we're still here up until tomorrow to witness this historic moment, but perhaps just to give us a recap of basically what has played out in this very day. The last speaker, that is the head of public service, Felix Kosgei, highlighting and insisting and as well confirming that the government is committed to ensuring that we achieve what is the aspect of universal health coverage, and highlighting the importance of the 4 bills that are set to be signed tomorrow by the President, the Facilities Improvement Financing Bill, as well as the Digital Health Bill 2023, the Social Health Insurance Bill, and the Primary Health Care Bill. I think these are very crucial things that will determine whether we push forward or not on the health sector.
Asante sana Linda, ndio umeguzia masuala ambayo ni masuala mazito sana, ikizingatiwa kwamba swala hili la afya limekuwa swala ambalo limepewa uzito mkubwa katika serikali hii ya Rais William Ruto, na ni katika kuendeleza tu zile juhudi za utoaji wa huduma bora kwa Wakenya, na ndiposa tumeweza kuona kwamba hili swala la maafisa ama ukipenda wahudumu wa afya ya jamii wameweza kuzingatiwa sana. Walipewa vifaa, ikumbuke mwezi uliopita tarehe 25 waliweza kupewa vifaa vya kazi, kuweza kupima joto, kuweza kusaidia wale wagonjwa wako mashinani kupata kukinga ili tusije tukaenda kutibu. Na ndio maana wanasema kinga ni bora kuliko tiba. Na siku ya leo kumekuwa na shughuli nyingi sana. Tumeweza kuona kulikuwa na mazungumzo wakati wa asubuhi, washikadau wa afya wakiweza kusema kwamba swala la wahudumu wa afya lazima liangaziwe. Na tunapozungumzia swala la wahudumu wa afya, tunaangalia maslahi yao, kwa sababu hapo ndo masuala ya human resource yanaingilia kati. Na bila kusahau kuna swala la ufadhili na fedha ambazo zinatengwa ili kuweza kufanikisha masuala ya afya. Na hapo ndipo tuliweza kuona viongozi mbalimbali walifika hapa. Kulikuwepo na waziri mpya kabisa katika masuala ya huduma za masuala ya Moses Kuria, na vile vile tukamwona mkuu wa utumishi wa umma Felix Koskei, waziri Susan Nakhumicha, wakafika hapa, ma PS walikuwa hapa, PS kadhaa wengi walifika. Alafu Muthoni pia, yule Mary Muthoni amekuwa kipaumbele sana pia katika kusukuma hili swala. Ameenda katika kaunti mbalimbali, alikuwa Kirinyaga juzi tu akiweza kuangalia masuala ya polio, na ni masuala ambayo yanaangaziwa sana. Na Linda, labda tukusie ili swala la wale ambao ni wahudumu wa afya ya jamii katika kile kibwagizo kwamba afya nyumbani. Umeona? Alafu sasa tuko na El Nino kama hapa Kericho.
Itakuwa ni vizuri, nafikiri tulizungumza na wao jana, wakawa wako na imani sana ya kwamba serikali ina uwezo wa kutatua matatizo haya. And why I'm saying, Joash, that this is the climax of the event is because we have witnessed the signing of the declaration, the Kericho declaration. You know very well that when you hold such conferences and have conversations as to changes that we need to make, the heart of it would be a declaration. And so this comes in handy towards, highlighting some of the concerns. And we have seen that they have acknowledged all stakeholders have been involved in this. And a couple of things that they have highlighted that is incorporated in the Kericho Declaration of Human Resource for Health in Kenya are amongst county-based training, which we say is crucial in terms of making sure that all these trainings are felt to the level of the ground, so that, when you're dispatching, the health or the medics, or even those ones that we consider as the health workers at the level of the ground, then we are certain that they're going to do the right job. They have also focused on, postgraduate training responsibility and how this is going to be fast-tracked and how it's going to be made better. They've also highlighted the health specialist sharing, which is very important across the different counties, the standardization of the internship programs that we have in the countries, the dashboard for health-related matters, as well as framework that is for transfer across the counties. Wamesema kwamba inakuwa ni tatizo sana wakati mtu anataka kutransfer, labda uende ukaishi na mume wako, labda uende ukaishi na mke wako, unakuwa na tatizo. Kwa hiyo wanaomba that they would fast track some of this so that at least medics can be able to transfer to different counties. Also, they have focused as well on the internship, that the government should ensure that there's opportunity for work for interns before they are dispatched. Yes, for a certain period before they're dispatched officially to go and serve, and also a comprehensive aspect of insurance that is for the medics, which is very, very important. Also, pending aspects of promotion and implementation, they request that some of these things would be looked at, and the engagement of Treasury in terms of making sure that there's harmonization of importance, the aspect of salaries for them, of importance also commitment of the unions. Nafikiri hilo ni jambo ambalo ni la muhimu sana.
Masuala ya CBA, utekelezaji wa yale ambayo yanafanywa ili kuweza kuwa na huduma bora kabisa.
They have said that they are going to seize any form of industrial action and give this declaration a chance to see the light of day. I think that is basically very, very important. And, just looking at this declaration and the numerous matters that have been captured in here, I think we are headed towards the right direction, perhaps, as a country in terms of attaining universal health coverage.
Na kufikia hapo, labda kwa kuangazia hilo, ikumbuke kwamba leo ikiwa ni siku ama ni kilele cha kongamano hili ambalo limekuwa la hamasisho, la kuweka mikakati, na vile vile sasa haya maamuzi ambayo yameafikiwa, tunatumai kwamba kutakuwa na afya bora. Na vile vile tuangalie leo ni tumemaliza, si ndio? Sasa tunasubiri Ijumaa UHC, Universal Health Coverage, awamu hii ni ya 3 isundiliwe na Rais William Ruto.
Na mimi nafikiri kwamba tunasubiri kwanza kuona kama rais atatia kidole au atatia sahihi,
kwa sababu bado hajatia.
Bado hajatia, na kesho, and they're informing me that some of these individuals that the CSS will actually be proceeding to Nairobi State House, so they can get to officially witness the president signing to bill or signing to assenting these bills to law tomorrow. So we can eagerly wait to see, and then upon assentment, then we certainly expect that the 20th March day there will be the creme de la creme of this. Joash.
Ndio, shukran sana Linda, tumekipiga na tunasubiri kukipiga tena hadi siku ya Ijumaa.
Kweli kabisa. Well, thank you so much as well for, keeping it at TV 47. It's at this point that we close. I think we also need to go and pay some bills. It's been a great session and we're looking forward to tomorrow. And finally, the Mashujaa Day celebrations right here in Kericho County. My name is Linda Alela. Thank you so much for keeping it right here.
Nami langu ni Joash Onsare, tukifanikisha kutoka hapa Kapkatet, Kericho County, na sasa tuelekee studioni.
Got a boy, but she don't really mind.